Good morning, and I would like to welcome everyone who is present in the chamber and those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would also add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep these succinct and concise. And as the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you very much, Chairman. We've received apologies from Councillor Thompson, Councillor Parkin, Councillor Sandra Harrison. We should have Councillor Mangian actually replacing, but he's not arrived yet. Apologies from Councillor Glynis Scalese and Councillor Kathy Rice-Oxley, who was actually attending as the sub today as well. I think we've also had an apology from Councillor Woolley. Thank you, Chairman.
Thank you, Trina. I'm sure some might be struggling getting in as well, so hopefully they'll arrive safely later. We'll now move on to agenda item 2, declarations of members' interest. Do any members have any interest to declare at this point? No, thank you. In which case we'll move on to agenda item 3, the minutes from the 9th of November. You'll find these on pages 3 to 13 of the agenda pack. There has been a suggested amendment to minute 15, specifically the first sentence of the 5th bullet point on page 6 of the report pack. This suggestion would replace "some concern was expressed to the fact that Lincolnshire had the lowest number of GPs appointed" to "some concern was expressed that Lincolnshire has the lowest proportion of primary care appointments undertaken by an actual GP. I need the committee's opinion on this because one member's put it forward, but obviously, you know, I need to see if the committee agree that that comment is correct or incorrect, as it may well be. Do members have anything to add? Councillor Smith.
Thank you, Chairman. I'm quite happy to second that.
Okay. It's been proposed by Councillor Cleaver, seconded by Councillor Smith. All those in favour, please show. Okay. That amendment will be taken. In which case, I'd like to now move, with that amendment, the whole of the paper from last month. Do I have a proposer for that, please? Councillor Cleaver, thank you. Seconded Councillor Smith. All those in favour, please show. Thank you. That's the minutes from the 9th of November carried. I'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated on the 8th of December and supplementary announcements were circulated on the 13th of December. Are there any questions on these, please? Councillor Smith first.
Thank you, Chairman. With respect to the duty of regard placed under the NHS in respect of members of the armed forces community, could we have a meeting with NHS colleagues to see how this will be properly implemented so that this very important population is properly cared for under the new statutory duty?
Simon, do you want to come in on that one?
Yeah, well, thank you, Chairman. If it is the will of the committee, and perhaps a small group could arrange a meeting, and we could get the relevant people from the NHS trusts and the Integrated Care Board to sit in as well, if that is the committee's will. Yeah, thank you.
Thank you. Do the committee support that? Thank you. Yeah. Okay. I've now got Councillor Wotton.
Thank you very much, Mr. Chairman. I'd just like to raise on your Chairman's announcements about missed appointments. If you remember last meeting, I recall informing you about the number of appointments missed at one of the surgeries in Grantham, particularly in nursing. During that week, there were 260 minutes of lost appointments. So if you think that every patient has 10 minutes, there's 26 people are missing. Well, that situation is still continuing in Grantham at a particular surgery. Is there anything we can do to publicise the need to make sure that people do get to their appointments on time? Thank you.
Thank you, Councillor Wotton. I'm sure that we can probably have a word and see if something could go out maybe in the county views and share that out, or certainly share it out on the social media and speak to our NHS colleagues to ensure that message is getting out, I think, for the whole of the county, really.
Thank you.
Thank you. Simon?
Councillor Matthews would like to say something. Councillor Matthews is online. Thank you, Chairman.
Okay, Councillor Matthews, would you like to come in?
Thank you, Chair. It's about the Armed Forces Covenant issue just raised by Councillor Smith. I'm the Lincolnshire County Council representative on the Armed Forces Covenant Board, and this matter is discussed at the Covenant Board where there are NHS representatives, and we have engaged with this within the council. So it may be that, although it's entirely right and proper that we express an interest in it may be that it's a right hand and left hand. I believe this matter is being dealt with at the moment and can be dealt with through the current channels.
Okay, thank you, Councillor Matthews. Perhaps we can have a conversation between Simon, you and I, and see what we can do moving forward. Thank you.
Okay, thanks.
Councillor White.
Yes, I'd just like to say that the Chairman's announcements, there just seems to be a lack of precision in the data. For example, the GP appointments, 19,000 unknown. And then as far as the review of the medical practices is concerned, I did look up the link. There are criteria, but there isn't very much information, or should I say it's categorised, but there isn't much information about criteria. And I would say that our local medical practice had a full review in 2016, I think that was when it last happened. These are just comments that I make.
Thank you. I would say that the NHS data we're told is experimental, and so at the moment in time that is somewhat, we can't rely on it, but they are looking to hone down upon that. And in regards to the CQC, we met with them yesterday, and the ratings that are there, they are being addressed, as much as possible on a monthly basis, I believe. So that's all I can sort of add at this moment in time. I've got Councillor Linderwood next.
Thank you, Chairman. I just wanted to comment on the fact that both Councillor Raywarton and myself were invited to the official opening of the 2 new theatres in Grantham. And my goodness, what a pleasure it was to see such a modern building with such an excellent facility. We were made very welcome by the staff, and they were all excited of working in this wonderful new building. And what an experience it is both for them and for their patients. The operating theatre, the main theatre, it was very modern and very space age, and they were all so appreciative they could work in this facility, and how great it's going to be, not only for the people of Grantham, the fact that it's something established on that site, but for the rest of the residents and patients from Lincolnshire that can come there and have their operations, because the addition of the 2 new theatres makes it 6 theatres in all, and they are getting on with the backlog of operations. Thank you, Chairman.
Thank you, Councillor Wootton. Yeah, it's very welcome to see it. I saw the news piece, and it's positive, and I think, as you say, very good for Grantham and Lincolnshire as a whole, and to see that we're now above the national averages, and one of the best sort of areas for that, I think, is very, very welcoming. So that's excellent news. Any further questions on my announcements? No, in which case, do I have a proposer that we note these, please? Thank you, Councillor Higgs. Seconded by Councillor Chalmers. All those in favour, please show. Thank you, they're supported. In which case, we'll now move on to agenda item 5, the temporary closure of the Hartisholme Centre. This item was circulated as part of the agenda pack on pages 15 to 24, and I'd like to welcome our presenters from the Lincolnshire Partnership NHS Foundation Trust, who are with us via Teams, Sarah Connery, Chief Executive, and Chris Higgins, Chief Operating Officer. There has been additional information in a short PowerPoint presentation due to be on the engagement feedback received to date. I'll now hand over to you for about 10-15 minutes to just sort of update on from where we are. Thank you.
Thank you very much, Chair. Hopefully you can hear me loud and clear. I just want to thank you for inviting us here to Health Scrutiny Committee today. I'm Sarah Connery. I'm the Chief Executive of Lincolnshire Partnership NHS Foundation Trust, and I'm joined by Chris Higgins, who is our Director of Operations, and also Andy Ricks, who is representative from the Integrated Care Board today. So I'm just going to set the scene a little bit in terms of the national and local context, and then hand over to colleagues to talk a bit more about the detail of the closure and also the engagement to date. to feed back to colleagues in terms of what we're getting from the initial engagement events that we'd held, and also from the online survey that we're running. So it won't have escaped your attention that the whole of health and care is operating under really challenging circumstances at the minute. This is across the whole of the NHS across the country in terms of staffing, as well as increasing demand at the time where workforce is leaving the health and care sector. I do know that you've had at a previous health scrutiny committee some colleagues from the system, including our own Director of People, to talk about what we're trying to do around recruitment, retention, new roles, ensuring people have got doable jobs, making sure that we've got excellent data and a really strong pipeline in terms of turning the tide to make sure that we've got a resilient, happy and healthy health and care workforce. There's much to do, but we're seeing some green shoots as a result of this work now, and our turnover rate over the past few months has actually started to dip, so that's quite positive, but much more to do. The key point is that we need to make sure that our services, while all that work is going on, are safe now from a patient and a staffing point of view. Hence why we have had to take the difficult decision to temporarily close our psychiatric intensive care unit, also known as the Heartsome Centre. And Chris will be able to talk a little bit about the psychiatric intensive care unit, how it fits into our acute pathway. I just want to reiterate and underline that this is a temporary closure. We're not testing out additional models. We fought really hard for our psychiatric intensive care unit in the county, which only opened in 2017. And our ambition is to remain providing psychiatric intensive care in the county for males and females. At the minute, for females who need PQ services, they do have to travel out of county. And while we have this temporary closure, then males are also having to travel out of county. So this isn't about stopping anybody getting the care that they need. It's just they're having to go a little bit further afield on a temporary basis while the temporary closure is underway. And we're tracking that very, very closely. Why it's the psychiatric intensive care unit, we're seeing significant staffing pressures across all of our inpatient wards, but we made the decision around the PQ because it was the least impact to the least patients. And again, Chris will be able to talk a little bit more about that. So I'll hand over to Chris now, just to talk through some of the detail. Thank you.
Thank you, Sarah. So you just to start off, it might be helpful if I just give a bit of context about what the PQ does. When you talk about intensive care, I think your mind automatically goes to things like you see on casualty on the TV and intensive care units. It's different in mental health care. Intensive care is around the level of security and the level of staff to patient ratios that are required to support people that often present with quite challenging behaviours. And nobody really gets admitted directly to a PQ. They're admitted to an acute ward first, and only if we can't manage them in that kind of environment, a more open environment, do we admit them to a more secure and specialist environment. And it's really designed for only a very small number of people with really high complex needs. And as Sarah said, in other counties, often a regional solution is provided for PQ care because it's a really small volume of people that's for any one geography, and that's the arrangement we've had for females for some time. However, we recognise that these are Lincolnshire residents, people that we want to support locally, and we feel we can give a better deal to closer to home. So we fought really hard, as Sarah said, to provide a local male PQ and wanted to do the same for females, but we've got kind of temporary step back just due to staffing situations. So where we're at really is that staffing's been a real challenge across our inpatient units, and as we looked at that, we've known that for some time. We've been doing lots of initiatives to try to get staffing levels to increase, and we've been managing that quite effectively for some time. However, the situation's just deteriorated over the last few months. Some of the after effects of COVID, some just general turnover, and I suppose the range of opportunities that staff in NHS and particularly mental health services have now got. and working in some of our inpatient environments are not as attractive to some staff as they are to others. It's 24-hour care. It's quite specialist environments, quite intensive behaviours that you're trying to support. And so attracting staff to work in those areas is proving to be quite difficult. We've got a number of initiatives to improve that, which I'll come on to in a minute. But we just reached a tipping point, which led to the emergency decision to temporarily close the PQ. And that was based on feedback that we'd heard through various surveys and our general feedback through our Freedom to Speak Up Guardian on different routes around what it felt like for staff working in our inpatient environments. And then it followed a specific proposal by the most senior clinical staff in the adult inpatient division to say we've reached a point where it's no longer safe to continue to provide care and treatment in all these wards. And so we had to make a decision around what to do around that. And as an executive team, I felt it was the right decision to reduce the number of wards that we're covering in the acknowledgement that there is appropriate and available beds for the people that need PQ care outside of Lincolnshire. So when we're looking at the different wards and what would make the biggest impact, the reason we chose the PQ specifically is that there's a smaller number of patients in there, as Sarah's has indicated already. It's a 10-bed unit. We've had it reduced to 8 beds throughout COVID to enable a bit more distancing in the unit. And it's actually been operating on somewhere between 4 and 6 patients at any one time would be in that unit. So it's a smaller number of patients than any of our other wards. And I think if we tried to close a different ward, we wouldn't have been able to find the beds out of area or elsewhere to be able to place them safely. And so we knew we could do that for PQ. We've also got a really experienced and resilient group of staff working on the PQ. These are highly specialist staff that we knew we could redeploy to other areas with really great effect. Whereas we've tried in the past to redeploy other staff into the PQ environment, for example, and that's not worked, where staff have found really uncomfortable and not skilled and not capable to work in those environments. So least number of patients and a really experienced group of staff that we knew that could have a really good impact on other areas. And I suppose in essence, that had two benefits to us. One is that it had the least impact on the staff because they feel more capable of moving and have done in the past. But also we knew that those staff could fill gaps in other areas and really add value, which we're actually seeing the benefit of already. So we looked at, and we've been challenged ourselves and been challenged by other stakeholders to consider what impact the temporary closure would have. Both in terms of impact on other services, but on the patients themselves. And the service said the reality is that for these small number of people, like is already the case with females, these men are going to have to travel a bit further to access their care. What we've done is we're working with other neighbouring trusts so that we've got contracts with those neighbouring trusts so that people can be placed as close to home as possible. Usually Nottingham is our main point of call because we've got a really good relationship, and we've got a really robust bed management team that consists of trained professionals that go out regularly and make contact with the patients and those care settings so that we can maintain that contact and that continuity of care. And as soon as they're ready and fit for discharge, they can come back into one of our local units or back into the community. So we maintain that healthy relationship, and that's something we do for females as well. What I'd also say is that for future patients, that will be for all the time of close that people will have to travel outside care. And what I would say, just as a person, as a member of staff, as director of operations, is that care is good. It's good quality care. And if it was my friends or family, I'd be happy with that level of care. What I would prefer is it being closer to home. And so this is about just the distance travelled and the accessibility rather than the quality care that's provided. So in terms of staffing, what I would say just in terms of that is that you hear probably through feedback from other organisations like our acute provider that often rely on bank and agency to supplement their workforce. That's something we do in mental health, but there is a difference in terms of the type of care we provide. So much of the success of care and treatment in mental health services is predicated on a therapeutic relationship between the patient and the professional. And as you can understand, is having high turnover of temporary staff come into a unit, that's really hard to maintain that relationship. And so a heavy reliance on bank and agency doesn't help in terms of patient care. And so whilst we do use bank and agency to supplement our workforce, it can't become the mainstay of our workforce in our inpatient wards because of that reason. So it has to be balanced out. Equally, our access to appropriately trained and experienced staff to work in our inpatient environments through the agency route is limited, and we do use it. We try to block book on agency if we can to get prolonged periods to create therapeutic relationships, but it's really tricky to get those staff through that route as well. So we're in a position where we've got the temporary closure. What I would say is, you've heard through myself coming to talk to you about Ashley House and the places where we've done a temporary closure through different reasons, and we've piloted a different model, an alternative model of care, and that's in the case of Ashley House, who I previously spoke about, has proved to be really successful, and we're considering whether that should become a permanent a permanent situation. Where that's different to the PQ temporary closure is that we aren't trying an alternative model here. This is a temporary closure. Patients are travelling out of area and will only do so for as long as is absolutely necessary. And then when we're in a position to reopen, then we'll bring them back and re-provide in county. It's absolutely ambition to do that. I personally fought long and hard to get the PQ open in Lincolnshire. I want to see it open again. I also want to see the same provision for females. It's something we want to do for the local people. But here and now, we just haven't got the sufficient staffing to be able to do that safely and appropriately. What we're doing about that is working really hard to be as challenging as we can be and as ambitious as we can be with our recruitment plans. So we've got traditional recruitment, as you would imagine. We're trying to do recruitment and retention incentives, both financial and non-financial, to attract people to work in our wards. We're also looking at new roles and seeing where we can test that out, bearing in mind we do need appropriately trained and qualified mental health practitioners, but can we try different roles? Can we use from other environments to be able to come and supplement our workforce, and can we get the same outcomes? We're also working with the local university to try to increase the pipeline of trained professionals coming through that route, and we're reaching further afield. So we're working with collaboration with other organisations to tap into international recruitment, so that we can see if there's other people with appropriately trained staff that could potentially come and work in the UK and work for LPFT. And so we're exploring a number of different fronts to try to be able to maximise the pipeline of people coming to the organisation, so that we can get the wards fully up and running as soon as possible, and hopefully in time expand that offer even further to females as well. What I would say then, in terms of where we're at now, we've got the temporary closure, we've started some engagement, there's more to do, which Andy will pick up in a minute. The initial feedback from there, we've created a few slides. I won't run through them now, but we'll share them with you afterwards. But some of the things that are coming out are that the majority of staff understand why the decision is being taken and sympathise with the staffing challenges. About 80% of those surveyed felt that. There's questions around how long the temporary closure is going to be. I'm sure some of the questions you like to have yourself is, how long are we going to be able to do this, and where are we going to get to that tipping point in terms of suitable staffing levels. Obviously, there's concerns from staff around people having to go out of county to access the care, which is against what we're trying to do as an organisation and as a system. So understanding people are concerned about that, and we're trying to reassure staff wherever possible. There are some feedback about the challenges with the Hearts Home Centre itself and the environment. It's quite a small ward and quite a confined space, and a number of staff have come forward to say actually the environment doesn't lend itself best to this kind of type of care for that number of patients, and is there anything we can do to adapt the environment to make it improve? So we are going to obviously take that on board and have a look at that. There is general support to maintain PQ services in the county. That seems to be a general theme, and there's general recognition that the current staffing is not sufficient, and the risk to quality and safety that presents are obvious. And again, that point that I was making before about that, really need to avoid a reliance on bank and agency to staff up, because it's not the best method of staffing an inpatient mental health unit. So just to say, we've had a number of engagement events so far. We've done an online survey, but we've also done a number of physical events in various locations around the county, just to try to give everybody the opportunity to be able to engage in that process and provide their feedback. And we'll be collating all that as we go, and that will inform our next steps. So I think that probably brings us to the end of my section, and I'll pass over to Andy about where we're going next steps.
Thanks very much, Chris and Sarah. I think it's important for the committee to hear that the ICB and the executives have looked at this in significant detail and had some very robust, open and frank conversations with our colleagues from LPFT, and it's important to note that we do support the temporary closure, and we further note the absolute ambition to reopen that unit as soon as is possible, and we can ensure safety of patients and safety of staff and communities. But I think Chris has articulated quite clearly that if you apply the principles of, Starling's law, you can keep on stretching something and stretching and stretching, but at some point it will break, and LPFT had to make a decision before something did break, and we noted and agreed that it was the right thing to do. So in terms of next steps, we've added in an additional engagement session in the new year. We've extended the survey that's being undertaken to take back views from both staff, communities, patients, carers and citizens. And once these have concluded, will obviously give us the opportunity to look at the rationales and seek views. We'll analyse all of the feedback and take that to the stakeholder event in February that is planned. And there we will feed back what we have heard and what we have seen, look at the impact on other services, look at the data, and we'll need to set the parameters collectively of when we feel it's the right time, the safe time to reopen. And we can talk about parameters, but the simple ones are having the appropriate number of suitably trained staff, that we've got a robust, sustainable workforce to be able to provide the right care. Clearly look at the workforce plan, look at the roles that are required and any alternative roles that could come in to support. And then finally, we are monitoring daily and weekly the impact on individual patients. And as Chris said, the numbers are very small. I think at the point of the decision to close, there were 4 patients in the unit, and all had plans to be cared for appropriately to either step down into less secure settings or arrangements for them to go to a neighbouring psychiatric intensive care unit for appropriate care. I think it's important to note the ambition that LPFT and I personally have, that we can expand services in the future for females. It's not been an option historically, simply because there weren't enough patients to be able to get a critical mass, and it's not alien to many of us to travel out of county, for neurology surgery or cardiac surgery or spinal surgery or children's oncology. So it's the right and proper thing to do, to put people's care in the place where it is safest and where the expertise exists. And I'll just reiterate, we are committed to making sure that that happens in Lincolnshire as soon as is possible. So that's all I wanted to say, and I'm assuming we'll move into any questions.
Yeah, thank you for that. Yeah, we'll move straight into questions then, please. I've got Councillor Loughagan.
Thank you, Chair. And thank you very much for that report. I did attend the engagement session that was held in Lincoln on the 23rd of November. And I have a comment and a question. The comment is, what's refreshing about the way this is being dealt with is it feels like a fairly honest presentation of the difficulties that you are in, and is quite different from some of the items that are presented to this committee, which are full of spin, as I would say. So, and the engagement event was very, very helpful. There was staff there who had worked on the ward, and there were people, all kinds of representatives there, and it was a very, very useful event. My question is entirely predictable. How long will it be closed for? And what's your guess about that if you don't know? And secondly, what are the chances of getting a similar facility for females?
Do you want to go, Chris? Do you want to take that one?
Yeah, I will. So, yeah, it was a predictable question in some ways, but I'm not sure I'll give a specific answer as such. But what I would say is we just need to work through what is as Andy said, that critical mass of staff within our inpatient services that will give us a confidence to be able to open and basically reopen the ward and have enough staff to staff that effectively and not deplete the other areas, so that we're back here again in 6 months' time saying, oh, look, we went too soon. So we need to determine what that level is, and we want to use engagement. Really pleased that you've been involved in that. I want to use that engagement to understand what that looks like, what it feels like for staff, so that we're in a position where we're all in agreement that when we get to this level of staffing, we'll go and we'll open, and we're all confident that it'll be sustainable. So in terms of timeframes, really difficult to say. I think the engagement concludes kind of end of January, February time. So soon after that, we'll have a position of what those conditions are, what's that magic number as such in terms of staffing levels. And then we were working with our recruitment team in the meantime to look at what's our likely success in terms of recruitment. So we can look at our known turnover, look at what we're doing in terms of the different recruitment campaigns that I talked about, and what do we predict will happen, and hopefully that will give us a timeline when we estimate to have the right levels of staff in the trust. So so I don't really want to commit to a specific timeline at the minute, but by kind of March we'll have a really clear understanding of what those parameters are and what we think is going to be that trajectory in terms of workforce recruitment, to give us a bit more of a clearer position. In terms of female patients, similar, I think we just need to get to a place where, and hopefully through the engagement work, we talk to people about what that looks like. As Andy's talked about, is we haven't traditionally had the volume of female patients requiring this level of care that would warrant opening a unit on itself, but we've seen in other areas of the county the country that there's mixed units and different things. So there's other models that we might be able to look at that could lend themselves to Lincolnshire. So I think, again, we need to test out some of those ideas through the engagement work that can inform where we go next. But here and now, the priority is get males back in county, but as part of that work, it'd be sensible to consider what can we do for females and think about what's possible.
If I could just add quickly to that as well, thank you, Chris, that we have actually put in a capital bid for a female PQ unit. It was part of the new hospitals programme, so we haven't heard back yet, but I think it's just an indication of the commitment in terms of plugging that gap within the county. Also, just around the workforce pipeline, COVID hasn't gone away, and people be aware of circulating respiratory illnesses. We've got 4 outbreaks on our ward at the minute, on our ward. So, as we go through what will be quite a tricky winter, as Chris says, we need to make sure that we're keeping all of our open units as safe as possible. But there are some unknowns in terms of those infection rates as we make it through the next couple of months. Thank you.
Thank you. If I may, just before I bring in the next speaker, just sort of adding on to Councillor Loughagen's question, how long can a temporary closure remain before, in essence, it is viewed by NHSE or I as permanent, as we've found in places like Grantham?
That is a very good question, and I'm not quite sure what the answer is to that, if I'm being completely honest. But in terms of conversations, would be, we don't want to commit to any time frame, but it will not be over 12 months, I suppose, if we want to put an outline on it. But yeah, I can go back and check what the official definition is. But it's certainly not what we're expecting to be classed as permanent for this unit closure.
Okay, thank you. I think it'd be useful to try and get that information over, because we have seen it used in other cases, not saying that this will be the same. I've got Councillor Chalmers next, please.
Thank you. I feel passionately upset about this closure. I think it's really disappointing, and it's not a tick box exercise. I've listened to you all talk, and I'm hearing buzzwords like we are hoping, exploring, likely success. Nothing is confident in what you're saying in terms of recruitment and pulling people into the positions that you're struggling to fill. Lincolnshire is the second largest county in England with 2,687 square miles, and we're sending people away from this area at a time where there's a massive cost of living crisis. So even if the patient is being transferred by ambulance, I'm assuming of some sort, their visitors might not physically be able to pay to go and see them and help them on their journey to recovery. Why are the staff unavailable in your area? Recruitment is a problem across all industries, not just the NHS, and this isn't going to go away with international or adding students. That's not going to have an impact today. So why are the staff unavailable? Are they leaving? Is there exit feedback? You've thrown in the old chestnut of COVID, but that isn't leaving at all. That's with us forever. And I'm afraid it is kind of wearing a little bit thin, because we hear it every month that COVID is a reason. And actually we should not be saying, oh, it's okay, we've got COVID issues, because everybody's going to have COVID issues moving forward. You should be coming to us and saying, we have COVID as a problem, and these are the things that we're putting into place because we know it's going to be a problem. What is the physical cost of having an unmanned facility or unit to the NHS? Because you'll have the space sitting there not doing what it's supposed to do, is another question I've got. I just found this really sad, and I'm hoping that you will be able to come back to me with some real tangible answers as to how you're going to make this as a short a closure as possible, please.
Yeah. Do you want me to pick up, and then maybe Chris and Andy will want to come back in, because there was quite a lot of challenge in there, Councillor, and thank you for your question. So if I pick up on the first one in terms of the unmanned estate, whenever we do temporarily close a unit, we will of course try and mothball as much as possible to reduce any ongoing revenue costs. But we are trying to take the opportunity in terms of enhancing the environment while it's closed, to take that opportunity. It's really hard to do building work on a unit when you've got 8 patients mulling around. It's not really safe when you've got builders and engineers in. So we're taking the opportunity to do some remedial works and improve the environment while it's closed. In terms of COVID, you're absolutely right. It's not going away, but it does make it really difficult to sort of forecast with certainty in terms of what the staffing might look like over the next few months. But what we've taken is a scenario-based planning approach, so we can look at worst, best and most likely scenarios. And the decision we've come to, which was a really difficult decision for our trust board to temporarily close the unit, was even in the most likely and best situation, it would not be safe for us to continue to operate those services over the winter months. So I don't know, in terms of the previous Health and Wellbeing Board, Health Scrutiny Committee session that you had with our people directors, hopefully there was some assurance provided in terms of we're leaving no stone unturned in terms of recruitment and retention. And in terms of our own retention programme, we've done a lot of staff engagement. What is it that will help you stay? What is it that's encouraging you to leave? And the 2 factors are pay, which we're unable to do anything about. We try and improve our financial and non-financial incentives within the parameters. But the second one is burnout. And the one thing that we could do is temporarily reduce one of the services to try and alleviate some of that burnout pressure. People have been working full gunnels over COVID and through COVID, and still as they do today. We've had increasing demand for our services, and those people that are turning up for support are increasingly complex as well. So all of our staff are having to deal with that. And for some people, it's just too much, and so they're leaving for other sectors. So I'll stop there. I don't know, Chris and Andy, if you want to come in with anything.
Yeah, I'm happy just to add. So I think one of the things as well, it's having worked in mental health services for a long time, like 25 years or more, here in Lincolnshire, is money to expand and grow services has been really hard to come by. It's been really difficult to get investment, and we've had to fight hard for every penny, including the opening of the PQ, which I think myself, Sarah and Andy were all involved in terms of trying to find a way to make that a workable model to be able to get the investment that was quite required. More recently, we've had a boom in terms of investment into mental health, and it's absolutely the right thing to do to get parity of esteem for people with mental health problems, and that has been brilliant to see. At the same time, what's happened is that investment has come quite significantly everywhere all at the same time. And so what we've done, both here in Lincolnshire and all our neighbouring counties and across the country, is expanded services that are much needed in things like perinatal, in urgent care services, in community services, primary care support. But that's created a lot of opportunities for staff. So we've got no less staff than we used to have. In fact, we've got more staff than we've ever had before. But the opportunities for people are just more available. And so we're in this kind of transition point at the minute. As those opportunities become available, there's a choice for staff between working in 24-hour services with patients that sometimes or quite regularly can be aggressive, can be really difficult to manage, or you can work in a community service where you can manage your own diary, go to your own appointments. And for a lot of staff, that's a preferred way of working. It's a preferred way for better fit for the lifestyle. So it's a brilliant thing for all that investment but the way that it's come, it's meant that we've created so many opportunities for people. It's an employees market at the moment, and that's why we're struggling in some of our really more difficult to recruit to areas, which for us is our inpatient areas. This is a here and now problem though. As those posts gets filled, we are gradually increasing the workforce. As we spoke about, there's some of the initiatives to really boost that. Those posts will become filled, and then there'll be less opportunities, and we'll create opportunities within our inpatient environment. People want to work in inpatient care, and one of the things we're trying to do alongside that recruitment is try to make our inpatient environments places people want to come and work, people want to come and stay. So what can we do to incentivise people both financially and other things, training and development opportunities, so it's a real specialist area that we can reward staff for staying. And so we are trying to do a number of things, but it is at the moment, one of the biggest obstacles we've found is, ironically, is the investment and growth that we've seen in mental health care over the last few years.
Thanks. The only thing I'll add is I recognise and accept the disappointment, and I think we're equally as disappointed that we've had to make this decision. But at the end of the day, patient safety is our number one priority, and the call has to be made to ensure the safety of patients. And yes, we might have said our expectation, our hope is to reopen at some point. We could have given you a day and a date. It wouldn't have been a sensible thing to do, because it would be disingenuous. We do have these conversations in an honest, open and forthright way. There's no hidden agenda with us. We'll tell you how it is for us and what we plan to do about it, and we will open the unit as soon as we can. But staff and people have a choice about where they work and what they want to do, and a lot of staff in the NHS are burnt out and decide to go and do other things that are not so emotionally demanding. So it is a real problem. We could get into a long and lengthy conversation about national policy, about training places, all of that stuff. But at the end of the day, we've got to deal with the reality of what's in front of us now. And all we can do is assure you that we will do everything within our power to get the unit open as soon as possible, when it is the right time to do it and when it is safe to do it. So I hope that's given you a degree of assurance about the concerns that you have. Thank you.
I am actually quite pleased with your answer. I feel that you've taken all the fluff out of the report and given me facts. And with facts, you've actually put forward some really important information, especially around burnout. And there are ways of dealing with burnout, such as making the job so it might be 4 days a week, in the unit and 1 day in administration, and breaking that job up. And you guys have the power with that information to actually adjust what you currently have. You also said about working in one of these man psychiatric blocks is very different to working in the field, where you can manage your own diary, and it's got all the, I suppose, the fluffy, warm entities of being able to do as you choose and clock off at 7 o'clock, which says to me that the two jobs are not the same job and therefore should not be banded the same. And this isn't the right forum to address that, but that is something that you need to work with recruitment and retention, and looking at the banding in which your staff are being applied to. But thank you for being honest with me with your answer. I do recognise the value in that it's huge value. Thank you.
Thank you very much.
Councillor Smith.
Thank you, Chairman. I'd just like to say I fully support what you and Councillor Chalmers have said. Whilst I take what's been said, it very much feels like here we are again, here we go again. I fully appreciate burnout without meaning to be too political. Before I ask my questions on pay, I think with what's going on in other parts of the NHS, all I'll say is be careful when a private on the army's £7 grand less and is having to lose their Christmas because they're covering strikes. I appreciate it's a different area, and I appreciate what the men and women in that unit do is hugely emotionally draining, intensive and difficult. And I certainly agree with Councillor Chalmers' point that actually that might be something you need to look at, which is not for here. But my questions are as follows, Chairman. It's the Trust doesn't foresee any reputational damage. I can see one straight away, and it's twofold. Firstly, there is the reputational harm of obviously you're closing a very specialist asset. I understand why and I take why. But that needs to be handled in a certain way to reduce as much damage, reputational damage as possible. And secondly is the confidence, as we've heard already, Chairman, both for us as councillors and also for our residents, confidence in the wider mental health system, if you lose one bit, starts to be questioned everywhere else, which is only human and natural. Councillor Chalmers touched on it, but I'd like to go a little bit deeper on recruitment because it's mentioned. This has been a huge problem for a very, very long time in the National Health Service. This is not a single government, this is a cross-governmental issue of any colour. The problem has always been, and has been since long before 2010, international recruitment was seen as a golden bullet that would never end, that it was cheap because we weren't having to create places, we weren't having to create training places, and we can pay some, and sometimes they were paid less originally on a ban when they came over. And those problems have come home to roost because when places like this and other people, a family member of mine included, when she used to work for the NHS in middle management, said all these things for years. Oh, no, it's not a problem, it'll keep coming. Well, those problems have come home to roost, and now to be blunt, Chairman, we're left with the consequence, and we've got to deal with that. And the only way you will deal with that long term is we need to have government and the NHS need to have a conversation of how many training places a year, how many medical schools. Appreciate that, and that's something we can lobby for. I appreciate it's not something that our presenters can do, but this isn't a new problem. This problem's been snowballing for years across the whole NHS, and it's come home to roost. And it's very frustrating that it's taken till now for people higher up in both central government and the NHS to realise this has now become a problem, when some of us have been going on about this for the last 10 years plus.
If I may come back on that, I totally agree that this issue of training of staff across all disciplines has been an abject failure in many ways. You don't have to go back that many decades to recall we had schools of nursing in Lincolnshire. We trained our own, they qualified in Lincolnshire and they stayed in Lincolnshire. We've lost that. That's very unfortunate, and let's hope that in the future with the university and the School of Medicine, etc. in Lincoln, that we might be able to reverse those trends. And in terms of reputational damage, I absolutely take the point, but I suppose I look at it from a slightly different perspective, in that there will be reputational damage or reputational concern if you close a service, but the reputational damage would be greater, in my opinion, if patients came to harm. And actually the damage that we want to avoid is harm. So, you know, we might have to take it on the chin in terms of reputational damage, but I'd rather deal with that than have to deal with reality of harm to patients, because we were trying to protect our own interests. That wouldn't be the right thing to do, as far as I'm concerned. But your points are noted, and thank you for making them, and thank you for your support actually in lobbying wherever you may around training. It's very much appreciated.
Thank you. I'm conscious of the time and I've got 3 more speakers, so I'm going to close the debate down after this point. I've got Councillor Mangion, and I hope I'm saying that right, Councillor.
Thank you very much. There's a couple of points. The history of closure of units in Lincolnshire is that they never reopen. I think that would be my first point. The issue has been raised that it's been staffing, which is the critical issue, and the issue of burnout has come up. And my question is, has the workforce strategy looked at the issue of burnout? And there are 2 issues really. One is the number of people staffing the unit. So the more work you pile on people, the greater the risk of burnout. And inadequate numbers are a big cause for burnout. And the other issue is the support for carers. So is there a mechanism, has there been a mechanism that will support workers? I'm not sure what a survey will do. The norms for staffing such a unit in terms of quantity and quality of staff should be well established in this instance. And I'm not sure that a survey will actually produce very much more. But I would be interested to know how the issue of burnout and recruitment will be addressed. In a sense, I do not see how you can actually recruit to a unit that is actually closed. It doesn't make sense to me. Once the unit is closed, it's closed. How can you recruit to it? I'd be interested to know what the strategy is of recruitment to a unit that is closed. Thank you.
Okay, thank you. Again, I'll start if Andy and Chris want to come in, but just to clarify, the staffing issues are across all of our inpatient wards and indeed some of our community services as well. So the recruitment isn't per se actually to the psychiatric intensive care unit, it's to our acute services. In terms of the staff well-being and the burnout, we have invested very heavily in terms of our well-being support for health and care staff. So we're sort of in partnership with the council as well in terms of that offer. So that's not just for our staff at LPFT, but it's for the acute staff, the community staff, as well as social care staff as well. And that's for people's mental and physical well-being. So for example, if people are suffering with their emotional well-being, they get a fast track referral through to our psychological therapies, for example, or if they need physiotherapy or occupational health. So we're doing a bit of an assessment to do a bit of a stock take in terms of whether that's working for people or not. For example, some of the feedback that we get is it's actually difficult to get the time to access. So how do we take support to people on the wards as much as expect them to sort of come out of hours for that support? I think another area that we're working hard on is around people's sense of belonging. So when they come and do work in health and care, you know, do they feel rooted and connected? Do they feel valued? Can they bring their whole self to work? And there's a whole separate system work stream that's building resilience around that. I think in terms of one of the councillors mentioned around flexibility, in terms of are these doable jobs to try and reduce that burnout. So we are looking at rotation roles, you know, people being in a certain position for a period of time and then going off and doing some community. So we're working closely with staff in terms of co-producing what that might look like. And for me, I think there's something about releasing time to care. It's quite an old buzzword that was a programme of work for the NHS, but I think we do have our staff completing a lot of paperwork. So we're trying to look at digital tools to free up to do the heavy lifting around some of that paperwork so that they are freed up to do the job that ultimately they train to do, which is to have, as Chris mentioned, therapeutic relationships with patients so that people can be on their recovery journey and discharged into the community as quickly as possible. So I know there's a lot in there. I don't know, Chris or Andy, if you want to add anything.
Yeah, just say in terms of the staffing as well, one of the things in terms of staff well-being is the environment in which people work, and just worth noting that we're just in the process of replacing our acute inpatient units, which are probably the least good of our inpatient environments in the organisation. They're not particularly brilliant places to work in terms of the quality of the layout and the fabric of the buildings and how we have to manage patients in those environments. And the new builds will hopefully provide a much better environment to work in, which hopefully will contribute to people feeling valued and wanting to work in the trust. So I just want to add that bit in. And also just in terms of the specific question about recruiting to a unit that's closed, it's something we're quite experienced in as we open new units, and I know often the committee will be familiar with units closing and the consultations around those events. But we have opened Ashville as an acute female mental health unit in recent times. We did open the PQ, and more recently we've opened the Urgent Assessment Centre at Lincoln County Hospital site. And each of those new initiatives, we do recruit prior to opening, so we build up the critical mass, let staff work in other environments until the point at which the unit's ready to open, we've got sufficient staffing, and then we go. So we are experienced in that, and it's a similar process we apply in this particular situation.
Okay, thank you. I've got Councillor Cleaver next.
Thank you. Could I just ask about provision in the south of the county? Based on what's said in the report, am I to assume that at the moment nobody goes out of county at all, even though the unit at the Poplar Centre in Peterborough is within a 25-mile radius of a lot of the south of the county, many of the towns in the south of the county, in fact, and will that provision be able to pick up, if it's not already being used, is there enough capacity there to pick up from the closure of this centre? Thank you.
I'm happy to pick that up. Just to say that what we try to do, we usually use our own PQ unit because it's the staff familiarity. We've got the networks of care and things that are more established, and so usually we would use our own PQ unit as default for patients that require this level of care. However, it's a patient choice thing. So if a patient lived anywhere in the county and would prefer to go to another unit that's outside of Lincolnshire, then we would absolutely support that admission. So it's not specific to where you live necessarily, but as default we would use the PQ, and everybody predominantly is managed within our own Lincolnshire-based unit. But if somebody chose to, then we'd absolutely facilitate that. So it is a choice.
Thank you. I've got Councillor Linda Wotton.
Thank you, Chairman, and thank you for your presentation. Most of the stuff that I've been thinking about has been covered. I think you've been very honest with us, and the councillors here have been very honest with you. My main thing is about recruitment and retention, which has been covered, so I won't elaborate on that. But I'll just say staff from Hashley House were brought into Lincoln to help out. So where are they? And Hearts Home, you've temporarily closed for however long. Where have those staff gone to? Have they been redeployed in doing other roles other than mental health? And also, we were told there's going to be a new mental health unit near Boston. How on earth are you going to recruit staff to work in that new unit? Although, from what Andy just said, I think it was, that people might aspire to work in a new environment, a new building, etc. Well, I jolly well hope so, because I think it's very important that we do have mental health facilities here in our county of Lincolnshire. Other than that, do we actually recruit with careers officers from schools and try and get children, students, to come and work in the national health care? And that's it, Chairman. Thank you. Just keep it short.
Thank you. I'll take each of those points in turn, and again, Chris or Andy might want to come in. So around the new unit in Boston, so just to confirm, that will be a replacement ward should our business case be successful and approved. So the staff are already working, we call it Ward 12 on the Pilgrim Hospital site. So the staffing contingent is already there. I'm very excited about the opportunity to be able to work in new state-of-the-art facilities. So we're really hoping that the business case will be supported. In terms of the Ashley House staff, they are now providing care and community rehabilitation services in the main. So that patient cohort will be receiving, as is our ambition for the Lincolnshire system, care closer to home in their local communities, in their homes, wherever that might be, with support from our community teams. And the feedback that we're getting from that service is excellent from patients and their carers, and indeed the staff contingent as well. In terms of the PQ staff, the Hearts Home staff, they have been redeployed to other inpatient units, but we're keeping a very close eye on them. We're keeping them connected as a team, so frequently they can sort of stay connected, have that sense of team, even though they have been redeployed. So we're putting that additional support in as well. So Chris, Andy, I don't know whether you wanted to add anything.
Just from a careers advice for school children. I mean, I don't work within education, and it's been decades since I've had to concern myself with what the children want to do for a future. But speaking to colleagues at work and who do have children at school and are reaching a point where they want to think about their future, my impression is that we don't, or they don't get the benefit of a sell of the NHS particularly, and that's something that may be
There's
lacking.
More to do. Yeah, there's definitely more to do in that sphere.
There's more to do.
Yeah, definitely.
And I personally went to Lincoln Uni about 5 weeks ago to speak to the second year psychology degree students, and not a single one of them had even considered a career in the NHS. But following that visit, which clearly must have been successful, some of them are. And one of the consultant psychiatrists from LPFT is actually going to touch base with one student in particular who wants to know more. So I know that there is a desire within some of the bread and butter degree courses at the uni to get more staff from the NHS to come in and talk to them about real life. So, but we've got a lot more to do.
We do have a talent academy that does go into school, a sort of an in-reach to talk to groups of students, but there's definitely more to do, I think, in terms of making more of those connections. So yeah, thank you for the question.
Thank you, in which case I've just got 2 questions to ask. My first question is, over the last few years, several mental health units have closed as a result of difficulties of recruitment and retention. Are we likely to see any further temporary closures or risks elsewhere on the horizon that we need to be aware of?
Thank you. Again, I'll take the question, and Chris and Andy might wish to come in if that's okay. So that is not part of the plan going forward, but as trying to see the positive as part of all of this engagement is it's given us an opportunity to connect wider with staff groups and service users and their carers about all of our inpatient facilities as well, and what good looks like. So I'll refer back to my earlier point about scenario planning as we move forward each month, that we're refreshing our predictive analysis in terms of where we are in terms of our workforce pipeline. And as we bring on more, we talk about international recruitment, for example, what will that deliver going forward? So no, I suppose in short, in terms of the future. If I just go back to your question though about what's changed over the number of years, we have, as Chris mentioned earlier, we have actually increased our staffing. Our actual whole-time equivalents have increased within the county, but it has been more community-based services, specialist services, as we talked about earlier, in terms of perinatal care, for example. So we're putting in services that have never been there before. It's just that the investment has come in quicker than we've been able to recruit. And there've been really exciting new services that have attracted staff to leave core inpatient and community teams and go and build these teams up. So you know, we do want to make sure that we're providing care as close to home in people's communities as possible. The investment is going in to strengthen those communities, make sure that people have got the support as and when they need it, and that isn't always in an inpatient ward. So that's what I'd add. I don't know whether Chris and Andy want to add anything further.
Only that the environment is changing around us, and significant emphasis on trying to deliver care in people's communities and in their homes as opposed to in institutions.
Okay, thank you. And my final question is there a financial impact on sending patients out of county for treatment? And if so, will this have an impact on other services going forward?
Do you want to take that, Chris?
Yeah, I can probably answer that one. Just say not in a negative way. Obviously, we will have to pay for the placements that we're sending people into, but that's offset by the fact that we've got obviously vacancies in the unit that's temporarily closed. So one will offset the other. And what we're actually seeing is those staff that have been redeployed into our other teams are covering shifts that would have to otherwise go out to agency. So potentially there's some net benefit, although we haven't worked that through at the moment, but it certainly won't be a negative impact financially.
No, I'd agree. There will not be any impact on other services due to finances. It's I don't want to say it's a non-issue, but in this very specific scenario, it's not a concern at all.
Thank you, that's reassuring. In which case, I'm going to move to a suggested proposal of that we accept the rationale put forward for the selection of the closure of the Hearts Home Centre, Lincolnshire's male psychiatric intensive care unit for temporary closure, to request that the feedback from the engagement is shared with the committee as soon as it is available, and to urge that the Hearts Home Centre is reopened as soon as there is sufficient staffing to provide a safe environment for both patients and staff. Do I have a seconder to my proposal? Thank you, Councillor Smith. Thank you. All those in favour, please show. Thank you. That's supported. Thank you. Yep, Councillor Chalmers.
Sorry, can we say when it is reopened that we find out about it, that we get that information back, please?
That will come back as, yeah, but that's carried, thank you. And I'd just like to thank our presenters for what was a very open conversation. So thank you. We'll now move on to agenda item 6, Lincolnshire Health and Social Care, Patient Flow and Discharge. This item was circulated as part of the agenda pack on pages 25 to 32, and I'd like to welcome our presenters via Teams, Andrew Morgan, Chief Executive for United Lincolnshire's Hospital NHS Trust, Michelle Harris, Deputy Chief Operating Officer for United Lincolnshire's Hospital NHS Trust, Nikki Pownell, System Flow Director for the Lincolnshire Integrated Care System, and also present in the council chamber, we've got Glenn Garrod, Director of Adult Care and Community Wellbeing. I'd like to hand over to you for 10 to 15 minutes, and then we'll take questions at the end. Thank you.
Okay, thank you, Chair. Morning to everyone. Delighted to be here today. Hopefully you can hear me okay. Also delighted that I am joined by my colleagues Michelle and Nikki. And just to update the record, as it were, since the papers went out, Michelle is now our Chief Operating Officer. Simon Evans, or our Simon Evans, as I call him when I'm with you and your colleagues, no longer with us at ULHT. So welcome Michelle in her new capacity as the Chief Operating Officer. As you said, Chair, you have a paper in front of you about all of our system work on how we improve patient flow, particularly in our acute hospitals. I'm not going to go through every bit of detail in that paper, but it does cover the work that's going on across the system, but also some of the work that's going on within ULHT itself. And at the outset, I would just like to thank all of my colleagues in ULHT, but also our partners in the system, including Glenn, who you've just mentioned, Chair, for the work that they're doing on behalf of all residents in the county to address discharge and flow. And I say that in the knowledge that we all have many different and competing priorities and pressures sometimes. And I know that through my lens as Chief Executive of the acute hospitals, I have a particular outlook on life and what needs to happen, but always aware that my colleagues, including at the County Council, have a range of other pressures, demands, and priorities. So I wanted to thank you and yours, but also our colleagues in the rest of the health service. The topic you have before you isn't just about Lincolnshire as such, and it's not just a topic that affects Lincolnshire. It's a topic that appears daily in the media at the moment, and is an issue that affects all health and social care systems across the country. And the two I usually draw people's particular attention to is the CQC State of Healthcare and Adult Social Care report, the one that was issued fairly recently, so it covers 21-22 year. And I think the very first line of the executive summary of that national report, and I'm reading, I think, verbatim at the moment, in 2022, the health and care system is gridlocked, unable to operate effectively. From an acute hospital perspective, I would endorse that statement, and I'm sure if you had my colleagues from around the country here, they would talk of similar experiences in their hospitals. And the second point, and this is the topic that went to the Health and Wellbeing Board last week, is that in the Chancellor's autumn statement, there was the confirmation of the additional £500 million nationally to help improve discharges from hospital. And the paper that went last week was about the share of that funding that's come to the County Council and to the Integrated Care Board that we can use on this topic locally. So not just an issue for us, but absolutely recognised at national level. And as this report makes clear, flow is both about what happens within the hospital, so the stuff that's within our more direct control at ULHT, but also the stuff that happens in the system, both pre-hospital, so before people come near our organisation, but also post-acute hospital, the stuff that needs to happen when individuals have finished their acute hospital care. And I do quite a bit of sort of media coverage on this because it's a very high profile topic. And we usually get into, during those discussions, some of the solutions that exist. And the things that get raised are about attendance and admission avoidance. So things like self-care pharmacies, 111, virtual wards, fall services, the whole range of things that are about how we treat people in the most appropriate setting, if that isn't the acute sector. Also get into issues about we just need to build bigger A&E departments then, or you just need to open more beds. Colleagues will know that the Lincoln Hospital site build is now near final completion. We have got plans to build a new A&E at Pilgrim Hospital. We've had the funding announced for that. So we are tackling that solution. And in terms of more beds, over recent weeks, we've had more beds open on our acute sites than we've ever had. Well in excess of 1,000 some days, getting near 1,050 on some days, when all of the plans we've got with the Integrated Care Board and others is that we should be operating somewhere between 850 and 900. That's probably a figure that needs reviewing at the moment to get a more accurate description of what should be the ideal bed level here. But it's clear we've been operating many days with in excess of 100 extra beds open. So we're trying those solutions. Key bit is you can just end up with even bigger areas full of patients if you don't tackle that other solution, which is about improving the discharges from the acute hospital. Because if that isn't tackled, it just gets overcrowded, it gets full, and you then become unable to take in more patients. And that getting the discharges right really, really does matter. It matters for the individual who is medically fit to move out of the hospital. And colleagues will know huge evidence about hospital-acquired functional decline. Being in hospital is not a great place for a number of people. Once they finish their episode of care, they do need to move on and out of the hospital, so it's bad for those individuals. It also stops us admitting new patients into the hospital. We can only have one patient in a bed at any one time, and if we've got people who finished their acute episode, we cannot admit new people. And if then we cannot admit new patients, but that we've got patients in the A&E department where we've made a decision to admit that patient, they therefore have to wait in the emergency department or nearby in one of our assessment units, waiting for a bed to become available. That creates some of those congested A&E departments that we are all aware of. And if the A&E is congested, that will often mean that we find it really difficult to take people off the back of the ambulances waiting outside the A&E department, and that then results in the handover delays that people will be aware of. And if then you've got ambulance handover delays, that prevents the ambulance going back out on the road to pick up those people who need the ambulance assistance. So when we talk about flow, really important that the back door matters in a hospital because it then backs up to the front door. The front door is the bit that's very visible, ambulances queuing, overcrowded emergency departments, but you can trace many of the problems back to flow through the hospital and problems with discharges. And we know that people waiting too long in A&E departments, too long for a bed, overcrowded emergency departments, that can cause harm to people. And we've put some of the research evidence in the paper about that link between harm, overcrowded emergency departments, and excessive waits. And I'm really clear and upfront with people that we have experienced some unacceptable waits in our A&E departments and some unacceptable waits to unload ambulances. I always apologise to patients for that. It's not something we set out to do, and I'm happy to apologise again in public today to those patients who have experienced some of those unacceptable waits, some of that overcrowding and poor flow. And I always add on an apology to my own colleagues for that, because I know that that's not the sort of care that they get up in the morning to provide. It's a circumstance we find ourselves in, but as a system, it is something we are trying to do something about, because we know it's there, we know it's a problem, and we need to make it better. And I'm also really clear when we talk about discharge and flow that this is not ULHT pointing fingers at everyone else. This is as much about our internal processes, our internal productivity, our internal efficiencies. It's about our need to get more productive wards, to get the continuous flow right through our hospitals. And we've made mention in the report of our Breaking the Cycle work that started on the 7th of November to improve that internal flow, to move some of that pressure from the A&E into the wards. But again, that will only be successful if we get the discharge bit right as well. So we need to work our patients up safely and quickly, get them to the point of being medically fit so that we get the length of stay as short as is safe and practicable, and at that point then discharge those patients as quickly as possible. But having accepted there are things that ULHT needs to do better, there are also things where we need help from our system partners those pathways of care that involve more support in people's homes or more support in other settings. So those pathway 1 to 3 cases. This is where we've been working well as a system to try and increase that capacity so that we can reduce the number of delayed discharges in our hospitals. And as the accountable officer for ULHT, my very simple principle and approach is that once an individual's acute episode of care has finished, so they are medically fit from an acute hospital perspective, we should not be retaining those patients in the hospital. As I said, it's not good for them and it's not good for the other patients waiting to be admitted. And I think as a service nationally, over many, many years, people have got used to their being medically fit for discharge patients in hospital. I'm clear that is not an acceptable position and is something we urgently need to tackle both ourselves, but also with our colleagues. And you can see why that's important when you look at some of the graphs and detail in this paper about on an average day, there will often be up to 150 or so patients who are medically fit for discharge, who do not need to be in the acute sector. And many of those will have waited more than 24 hours from being declared medically fit for discharge. One of the bits of work we have got to do as a system is agree the accuracy of the data so that we discuss and spend our efforts and energies on solutions, not arguing about, well, are the numbers 150 or is it 110 or is it 70? Whose responsibility are they? Absolutely accept we need to do that bit of work, but we do that bit of work from the principle that people who have concluded their acute hospital stay, whether it's 1 or 150, should no longer be in the acute hospital sector. So between us, we've done some great work to increase capacity. We've done some great work to address some of our internal processes. Both of those aspects are incomplete at the moment, but we look forward to continued work at pace to resolve this issue going forward. I'll stop at that point, Chair. I don't know if Michelle or Nikki want to add or correct anything that I've just said there. I'll leave that in your hands, Chair. Thank you.
Thank you. Is there anything further you'd wish to add at this point, or are you happy to move to questions? I'll take it. We're happy to move to questions.
I sense silence from my colleagues. They're happy
Absolutely.
to answer the difficult questions.
Thank you. Okay, we'll move on to the first question. Councillor Ray Wotton.
Thank you very much, Steve, Mr. Chairman. Good morning, Andrew. First of all, can I make a comment before I ask the question? As you know, I spent time at Lincoln A&E over 13 hours waiting to be admitted. But once I did get admitted, I received excellent treatment from your staff, and I thank you for that. But I received a comment the other night from one of my residents who had to go to hospital. He waited in an ambulance for 4 hours to get there, and also once there, he didn't get discharged until 10 o'clock the next morning. Now, you may wonder, that's not too long, but this patient was 102 and could have gone to Grantham Hospital. So I can't understand why Grantham could have been opened and not closed. On your paper, page 27, you've got 15% of patients could be seen at settings elsewhere. Do you accept that many patients want to get a GP appointment but can't get a GP appointment and end up going to A&E instead? Thank you, Chair.
Okay, I'll start with the second one first, if I may, Chair. I know that my GP colleagues are really, really busy. I think you had a paper here at your last meeting or the one before that, setting out the additional GP appointments that have been made available compared to sort of pre-COVID, what proportion of face-to-face and all of that. So I'm not about to sit here and again point fingers at my general practice colleagues. I think they do a fantastic job in really, really difficult circumstances. Having said that, we do know, because patients tell us sometimes, that they have come to A&E either because they have had difficulty in getting a GP appointment or have not attempted to get a GP appointment because they find it easier to come to A&E. A&E, the clue is in the name. It is there for accident and emergencies. It's not there for routine healthcare. But we know that people do turn up, and many people go through the urgent treatment centre part of our service offer and don't end up in the sort of majors part of A&E. So simple answer to your question, Ray, I think GPs working really, really hard, difficult circumstances. Some patients either don't try or have had difficulty, and yes, they will end up in A&E or the urgent treatment centre part. On your first point about the individual patient, always difficult to get into specifics as individuals because I don't have the details on that. Certainly long waits in ambulances, not something we endorse or welcome. We try to get those as absolutely short as possible. We do work with EMAS to make sure that patients are taken to the right hospital if they need to be transported to hospital at all. And EMAS do work really hard on sort of on-scene care or redirecting our patients to the most appropriate setting. So probably difficult to get into the specifics on that case unless Michelle wants to offer anything from a operations point of view. Michelle?
Yes, thank you, and good morning. Just in terms of the point, in terms of the vulnerability based on age, they are a group of our patients that we observe very closely to make sure that all of the care afforded to them is given in a timely way to try and compensate for the delay. Ultimately, what we are finding is that over a period of treatment and stabilisation, the patient that originally came to us from an emergency department point of view doesn't need to stay with us. And the best thing for us to do, if we've got an opportunity to do that, is to discharge them safely back to their usual place of residence. So again, can't comment directly, but outside of here, I'd be more than happy to look into more detail, providing that we've got the patient's consent to do so. Thank you.
Thank you, Chairman. Thank you, Roche.
Got Councillor Hakes next, please.
Hello. First of all, I'd like to say that about 7 or 8 years ago, I was on a team going down to London, actually looking to improve the discharge summary. I've spent 2 years on that, going down about 3 times a year. And I have to say, nothing's improved. Now, from my experience, because I've been in hospital a few times, and you're fit to be discharged, so, and you need a prescription. So you're waiting for your prescription. You could be waiting 5-6 hours just for a prescription, which is holding beds up. And I was told by a nurse, oh, you're low priority because you're being discharged, so other prescriptions are going in front. So the pharmacy, what could be done about that to quicken discharge of patients up instead of being classed as a low priority? Thank you.
Okay, shall I start with that? And I don't know if Michelle and or Nikki might then want to add something. On your first point about you were doing this same work many years ago, doesn't surprise me, but slightly saddens me or disappoints me, I suppose. This is a long-running topic, and it's got many factors as to why it's still there with us. Rightly or wrongly, I do say on occasion that I think we've normalised it. I think we've got used to it being as it is and are no longer shocked by it, both in terms of the discharge delays, but also sadly on occasion some of the waits that we have in A&E departments across the country. My approach as the chief executive here is to absolutely be shocked by some of the waits that we have, because they shouldn't be acceptable or tolerated. But the same principle applies to the back door of the hospital. It is entirely wrong that we have between us nationally not sorted out hospital discharges, and that includes the internal efficiencies and productivity of hospitals, which I think then picks up your second point about, on occasion, some of my staff viewing discharges as lesser priority than sort of hands-on care of active treatment cases or that. The two, of course, are linked, aren't they? If we don't get the discharges right, it does hamper our ability to treat those who may be in more urgent need of our care. So I'm not going to defend the comment about people being lesser priority. That shouldn't be what people say. And several hours delay for sometimes our diagnostic results, prescriptions to take out, discharge letters. Those are all of those bits that when you read today's report, you'll see we are trying to address, getting standard processes in, quickening up those processes, absolutely getting all of our teams through the clinical vision work that we've mentioned in this report, absolutely understanding the importance of pace and flow in our hospitals, because if we don't get that, that's why you see some of those front door delays that are entirely unacceptable. But I'll let Michelle add.
I think it's worth noting as well, we're doing a huge piece of work with our discharge lounges. So we have revamped them to make them a much more sensible and appropriate environment for our patients to wait in whilst they are waiting for what you just described, TCOs. Part of that is to re-look at the establishment. So not just having the nurses in there, but we've now got dedicated medical support for discharge letters. And I'm about to confirm with our pharmacy leadership colleagues having a pharmacy technician in there who will then move through any delays to a prescription. So you won't have to wait on the ward. Patients don't. They go into a very comfortable environment that offers a different atmosphere than the wards do. And then the rest of the activities that need to occur, such as the finalisation of the GP letter and also the delivery of the medicines to take home, has occurred there. So we are making sure that those areas are really responsive for your last experience with us in the acute trust. Thank you.
Thank you.
Thank you. I've now got Councillor Chalmers, please.
Thank you. I've just got a couple of points to make. My last experience with being discharged was when I was having my son, and the two nurses that were discharging us sat with their chairs back to back, but turned facing towards each other. And every time we went back to the reception to say, please will you discharge us? And it was just a matter of paperwork. We weren't waiting for any meds. They were talking, and they were talking about the weekend that had just been, and then the weekend that they were going to have, and the party. And in the end, it was an older nurse that kind of wandered through and went, do you know what, that'll take 2 minutes, I'll do that for you. And out we went. I can't say that's the case for everyone. I can only speak on my own experience, but that was my experience. It wasn't a very positive one, and I say bring back the sister, because she'd have made that happen. You said about the increase of beds. Well, we definitely need increase of beds because we have increase in population, whether they're transient population or real population. I don't know who we have here from Skegness today, but you only have to look at the people in, oh, sorry, Councillor Macy, the people that have been put in the hotels in Skegness at the moment. We need those extra beds. On top of that, we've got our smaller rural hospitals and A&E type departments that have been closed. So 100 sounds like nothing to me when you look at the amount of beds that have been displaced. But on to my question. On page 31, you have got, due to go live on the 5th of December, we're now moving the focus to the interface between blah, blah, blah. How did the live go? And is there any kind of report so far as to whether it appears to be making any positive or negative or no impact at all? What is the situation with that, please?
Shall I take that one, Andrew? Is that all right? Breaking the Cycle 2, I think, was the 5th of December date. So, hello, good morning. Nikki Powell, I'm the System Flow Director, and the work on Breaking the Cycle 2, which you reference, which went live on the 5th of December, was following on from the Breaking the Cycle work that the Acute Trust have done. The real focus was about making sure we really brought together all of our system colleagues who work at the interface at the back door of the Acute Trust. I've been in the system now a year, and we have spent a lot of time in, and the right, probably not enough time, we need to spend more time, focusing on developing our relationships, focusing on building trust, focusing on how we work well together. So what we've introduced on the 5th of December is Breaking Cycle 2, which was about maximising the capacity that we have in existence across our system in terms of beds and home care, and also making sure that we fully utilise the new capacity that is being brought on by system partners over the next few weeks to make sure we absolutely iron out any of the kinks or constraints to flow that we have. So all system partners meet at least twice a day to talk through the various challenges in moving patients out, and hopefully by working together, speed up the discharge. The aim was to try and bring it forward by 24 hours. Any of the patients who are medically fit and waiting to go out of the back door. We found a number of constraints which we're working on and trying to resolve. And interestingly, the biggest one that's come up so far has been transport, and how we actually physically move patients at the right time, early enough in the day, to get them admitted into, for example, I'll use this, our care homes. So my colleagues in the local authority that I work really closely with, who lead on the integrated discharge hub, or transfer of care hub as we've renamed it, have been putting in additional capacity in terms of both reablement at home through Libertas and in care homes, in something that I think some of you may have heard about, our new approach to reablement in care homes. So our active recovery beds, which have all gone live this week. So the idea of the Breaking the Cycle is to make sure we get the right patients and the right people moved into those care homes safely at the right time. So the active recovery beds, I think, are one of the best initiatives that I've seen coming through. I prefer patients going home, but there are sometimes patients that can't go home. You won't be surprised here, we've got a number of patients currently resident in the Acute Trust whose boilers have broken, whose home living circumstances mean that they're not able to return straight away. And so being able to give them that offer of a care home bed where they receive active reablement to actually enable them to get home after a few short weeks is a real plus for this system. And we've been working really closely to make sure that our care home managers that have recently been that have recently come forward to supply these beds, that they feel safe and they feel comfortable about accepting patients from the acute, because actually if we get this right, it will make a big difference for our capacity going into winter. Our reablement capacity, been working really closely with Glenn's colleagues and the commissioning, contracting colleagues to make sure that we absolutely use our Pathway 1 capacity as we should. So Pathway 1 is where we do that first offer of reablement, rehabilitation and recovery in somebody's own home before we even think about assessing them for any long-term care needs. The increase in that particular service has been superb. But what we've got to work on now, and one of the things that we're doing in Breaking the Cycle 2, is making sure we don't have failure demand, making sure that all the hard work that colleagues have done to work up the patient for discharge, we then don't lose that discharge because of something that we haven't done or we haven't put in place or we haven't acted quick enough. And that's been a real focus this last week in the calls that I've been on, is how can we improve that together as a system. I've worked in a number of systems over the years. Been very fortunate working at Region, working in other hospitals across the Midlands. And the one thing that struck me coming into Lincolnshire is there is the collaboration, the way that people are willing to come together from local authority, from our voluntary sector, from our community trust, from our acute trust. They really want to work together to make it right. And I echo what Andrew said earlier. They are as equally frustrated with any delays that they encounter. They absolutely want to do the best for the patients. And that's what Breaking the Cycle 2 is about. It's about making sure that we are doing everything possible to improve and continually improve the journey of our patients from the acute back into the where they should be. Thank you.
So is there any feedback yet?
I don't really want to go into numbers, but I can do numbers if you want. We've probably chosen the worst week to launch it. As I'm sure Michelle will echo, we have never seen the demand at the front door of the acute in the last, since we started Breaking the Cycle 2, in the year that I've been in Lincoln anyway. The numbers of presenting, particularly paediatrics, to our front door has meant that the demand on the acute services is huge. We've also had a number of staff gaps because of illness and needing to take time off to look after poorly children. But in terms of early outcomes, yes, we're putting in Andrew mentioned the discharge monies that's coming through. So using that discharge money, national discharge money, we are absolutely able to target specific areas. So we are investing in more Pathway 1 capacity. We are investing in more home care. We are investing in more care home beds. And we are investing in additional transport, as you'd expect, because it's criminal not to lose a discharge if we can't organise the transport. Those are the sorts of things that we are going through every single day. So in terms of outcome data, after only 10 days of going live, I can't give you any numbers in terms of we have reduced by, and we have hit our target of reducing the waits by 24 hours. We've got two big events. One was yesterday. We do something called a multi-agency discharge event, where all system partners come together to focus with the patient at the centre to make sure we put a correct discharge, the right discharge plan in. We did that for our community patients yesterday, the patients that are in community beds. And we're expecting we know we're going to have a big mass amount of discharges out of community hospitals over the next few days. We then move to the acute hospital on Monday and Tuesday next week to do the same multi-agency discharge event with the same, hopefully with the same output, that we will have increased discharges and therefore reduced bed occupancy in the acute trust to make the flow better through the system. The multi-agency discharge events are now a regular feature within our system. They're booked every 2 months and have proved to be hugely successful. But what we're hoping this time is that we can have that extra push because of that additional capacity that we've got in, because of the way that we're communicating together every day, twice a day, through the huddles in Breaking the Cycle 2, that actually as we get into the Christmas week and that 4-day bank holiday and going into January, that we will have really reduced the bed occupancy in the acute trust. And that is when I'll know whether or not Breaking the Cycle 2 has worked.
Okay, thank you. Councillor Cleaver.
Thank you, Mr. Chairman. Just to follow up on what's just been said, really, I noticed that, again, in the paragraph on page 31, the second paragraph, Breaking the Cycle 2, that we have a number of questions, but we don't have any answers. Now, I mean, it's great these questions are being asked. They clearly need to be asked. And obviously, one would express a concern that these questions should be answered as quickly as possible. Then moving on to next steps, again, a very short section, and only focusing on December and January, which concerns me somewhat. It gives the impression that we're only looking at a stopgap. Now, obviously, you can't spend money that hasn't yet been allocated. I get that completely. But I would have expected to see some more rather strategic next steps than simply how we're going to spend this £5 million that's been allocated for December and January. And moving into the detail of that, I noticed that obviously County Council is involved with this. It's a joined up integrated care initiative, and that again is a good thing. And the papers where the purchase of these active recovery beds, which were just been referenced, very interestingly, 60 of them, 20 in each of the east, south and west of Lincolnshire in care homes. Now, I'm concerned about the fact that care in care homes obviously involves our primary care networks. And my concern would be twofold. Firstly, that the residential care homes that are providing this service are ones which are rated as good or better by the CQC, and that the PCNs that are going to service the primary care needs of the 20 beds in each of these geographical areas are going to be served by PCNs, again, which primarily have GP practices which are not in special measures or requires improvement, and actually have the capacity to make sure that those people are properly looked after in those environments. So I know it's beyond the area, particularly of LHCP, but I would like, if anyone here can give some reassurance on that, I think it would be helpful for us, please.
I can speak, and I know Glenn's in the room, so I'm sure that he will be able to confirm what I'm saying is correct. The procurement of those 60 rapid active recovery beds has been led by Alina Hackney and the contracting team within the local authority, and they've been very, very clear in terms of the CQC rating of any of the capacity within the care homes that they have secured. They went through a very rigorous procurement timetable. I think that both Michelle and myself and Andrew probably wanted those beds opening about a month ago, but quite rightly, they have taken the right procurement approach and have been very thorough in making sure we've got the right care homes engaged with us. And it's great thanks to the team that have led that by the local authority. So Tracy Perrott has been the lead for that, for the system, who is one of your heads of social services, adult social care, working with us in the acute sector. So I personally am assured that they have done everything in their power to make sure we have got the right care homes with the right abilities to be able to support. And in terms of GPs, we do have primary care linked into all of our conversations about our capacity. And there has been a new GP contract put in place in terms of payment, an agreed payment with the local GPs to look after those additional patients coming into that care home. That's been very key. It's been linked into the Enhanced Health for Care Homes work that our ICB lead on, but that contract has been done as part of our winter planning to ensure that any patient who is moved into either an interim bed, which we've been using in the system for quite a while, or into one of our active recovery beds has got the appropriate GP coverage. And that's ongoing, and that has all been confirmed to be in place. Otherwise, we would not have gone live with those beds on Monday.
Thank you for that reassurance.
Thank you. I've got Councillor Mangion.
Thank you. Thank you for the presentation. It's reassuring to see that there's a lot of work being done in the discharge process. My question really is, what scrutiny has been made of the internal processes within the hospitals, acute hospitals themselves? So, in other words, has the waste within the process of care within a hospital actually been looked at systematically? An example, for example, would be multiple transfers among wards, which is recognised to delay discharge and impair care. And the second question is really looking at those processes, has the effect of numbers of staffing and quality of staffing been systematically analysed? Are there actually enough people on the ground to provide effective care during the hospital stay that will actually facilitate the process of care and allow a speedier discharge? And the last question is, with all these, with all this focus on discharge, has the effect, the possible detrimental effect on care been analysed? In other words, what is the effect on readmission? And if the data is not there at this point in time, is there a plan to actually monitor readmission as a result of these introduction of these processes? Thank you.
Okay, thank you. A number of questions there. I'll try and answer as many as I was able to write down, but let Michelle and Nikki add. In terms of the scrutiny on the internal processes, there's been both scrutiny and significant external input, and I think the report does mention the reference to the emergency care intensive support team, the involvement of Empower, which I think is a consultancy well known to the County Council, as well as our CQC colleagues and colleagues from NHS England. So considerable help, support and input, all of that alongside the work we're doing through our own improvement methodologies and input. I think, as I tried to make clear in my introduction, the work is not complete. We know there are still things that we need to do to improve our internal processes. Some of that's about some of the professional standards work that again gets a mention around the work that Ian Sturgis has been helping us with. But yes, lots of benchmarking, lots of model hospital data, which compares us and benchmarks us to other organisations, and lots of work around behaviours, culture, leadership, variation in practice in our trust, adherence to standard operating procedures. All of that, I think, is wrapped up in the point, Councillor, that you were making there. And I hope in my introduction I made clear that we absolutely accept there are things we need to be better at, as well as things that our partners need to be helping us with. I think your second point was about staffing levels and appropriate staff. And again, it goes back to the issue of bed numbers that I think was one of the previous questions. I think we do need to do a bit of work to sort of reset and recalculate what's the ideal number of beds that our hospitals need, accepting that as a system, we are very much focusing on home first, care close to home, and not just creating ever bigger acute hospitals. And that's partly about the choices we would need to make. And I'm sure many of the items you have regularly here at Scrutiny are about, as I think I just came in at the tail end, mental health, primary care, community. If we want to spend all our money in the acute sector, that's a choice we can make. Don't be surprised then if you don't have the mental health community primary care service that you want. I think that would be the wrong choice to make. We need to be effective. We need the right number of beds if we get the flow and the pre and post hospital services right. What we do find when we have surge beds or additional capacity open is that we do become reliant on agency and bank staff, many of whom are absolutely excellent, well known to us, but it does mean our own staff also get moved about from their home ward occasionally, moved about between sites as well on occasion. That isn't ideal in terms of getting our staff to have the time to focus on the discharges and not have them focused on just doing tasks to keep people safe when you are coping with an excess number of beds. So all of that work on length of stay and all of that work on the discharge is about trying to reach the right number of beds staffed with our own staff able to do the hands-on care, but also able to do that planning of discharges that is so needed if we're to deliver some of those longer term issues that are set out in this report. I'm now trying to remember your third point. I think it might have been about some of the data on readmissions and the like, which I'm sure Michelle may have some of the facts at her fingertips as she normally does. Michelle.
Yes, thank you. So you made two further points. So the multiple moves, extending length of stay. We've done an awful lot of work. So what we now do is we identify outside of the patient going from the assessment unit to the base ward, if they're requested to move again, there is a full assessment. We don't allow our patients now to move more than twice, and there has to be a very valid reason for doing so. If they're moving through into a less acute stage and they're suitable to do that, we do that in conjunction with their lead consultant. So the lead consultant will identify patients on those specialty wards. If they can now move because they've achieved the therapeutic component of their care, then they will be the people identified. We don't allow the same patient to be identified all the time to move. As you've described, that can add at least 1 to 2 days into their care journey, because people need to become familiar again with the person themselves and any underlying conditions on how we manage that. So from a readmission point of view, I have a daily report of any patient that is readmitted to any of our acute sites. And what we then do when we trigger a 2 readmission, then we look more closely and scrutinise, did we miss something? And I don't mean in the treatment pathway, but was there a social, economical situation that we didn't pick up, which has led them to come back in? So we then do what we need to do to enhance the wraparound. We pay special attention as well to those patients that have a readmission cycle from care homes, and we work very, very carefully and closely with adult social care to understand, are their needs being met, and what can we do as a joint care health and social care offer to make sure that that patient settles more confidently within that environment. So they're the two processes that we have put in place, because we did note, being candid, that a number of patients were being moved a number of times, and that was in response to the front door. And it goes back to the whole point, if we can get the flow out, then the intention and absolute would be the patient's stay will be in that ward they first went to, so we can really enhance their recovery in a much more speedy manner. I hope that answers those other 2 points. Thank you.
Thank you.
Okay, thank you. I've got 2 more speakers, and then I've got a couple of questions myself, and then I'm going to close down the debate. Councillor Smith.
Thank you, Chairman. Just before I ask my first question on the issue of the premise of flow and what we've been discussing, this isn't new. The late Councillor Strange, I always remember when we were serving on district together, always used to mention to me cottage hospitals, which is exactly what they used to do. They weren't there for acute care, they were there to do rehabilitation, physiotherapy, those sorts of things, until you were in a state to go home or wherever your residency was. They were then closed many, many years later, and since then we've had this problem of bed blocking. So this isn't a new fandangled thing, it's a new way of doing something that's already there, and I think we need to not reinvent the wheel, because the wheel's already been invented. We might need to add a few spokes to it so it functions, but there's no point trying to reinvent something that actually used to work quite some considerable time ago. I've heard a lot, and Andrew mentioned quite a lot around the issue or around in terms of preventative care prior to going into an acute, to use, say, UTCs, pharmacies, GPs, etc. Most parishes in my patch don't have their own pharmacy, for one, because it's very rural. They certainly don't have a UTC, and a lot of them, the pharmacy is attached to the GP surgery, so once it closes, the pharmacy closes. And I take Andrew say there's certain things that I think people need to be mindful of, that people will turn up to any because they have no other options still. And whilst I appreciate the Chief Executive doesn't really want to air dirty laundry in public around the issue of access to GPs, I think there's still, as you'll know from our issues we've discussed here, Chairman, both need to have a very frank conversation, an honest conversation with each other in private of what they expect from each other, so that our residents can get the best from both of them, because certainly there's a break in the chain somewhere, and from my experience, it's at the GP end.
Andrew,
Okay,
I don't know if you want to add anything.
I don't know if there's any question as such, but just to reassure the councillor on that last point about the parties getting together, I think I am at the ICB's primary care group this afternoon, absolutely having discussions with my GP colleagues about the two-way help that we can be to each other, but help that we can be to each other so that between us we're of help to the patients and residents of Lincolnshire. So that will be about things that I need to do to help my primary care colleagues and the things that they can do to help us. And hopefully they will undoubtedly be things that help our local residents. In terms of the first point around cottage hospitals or community hospitals or other people's beds, as I often describe it, our whole approach is very much a home first and care close to home model. Many colleagues get bored of my trite comment on occasion that there are enough beds in our system because we've all got one at home, or at least one at home, and that should be the natural place for people to be, unless their care needs are such that they need to be occupying somebody else's bed. And that might be a bed in a care home, it might be a bed in our community hospitals. And as the ex-chief executive of the community services in Lincolnshire, I'm well aware of the community beds operated by LCHS and the great work that they do. So sometimes it's about what we call things. Sometimes it is about there's nothing new in life, that some of this is a return to the same sort of topic. But my simple message doesn't change. The flow is really important. And the whole issue that I think a number of colleagues have said today about this isn't anything new, is it? Absolutely right. But isn't it therefore about time that we did everything we possibly could once and for all to get ourselves into a better position than we have been to of late, particularly noting Nikki's point about we're in winter now. The demand is quite extreme some days on the acute hospital sector, as well as on all the other sectors. All the more reason why getting the flow right becomes even more critical if we're not to have overly congested A&Es and ambulances unable to hand over patients and therefore unable to get back on the road. Thank you.
Thank you, Chairman, for allowing me to come back very briefly. Andrew, you said it's not new. What caused the system then to take that element that you're putting back in? What made it take it out in the first place? Because if it works, which it did, and I appreciate you may not be able to answer this, why was it then taken away to then be put back in now?
We could have a long debate about health policy. It depends what we mean by taken out. There are still a number of community hospitals in Lincolnshire, which for a geography like ours is entirely appropriate, whether those are for step-up facilities, so to avoid people having to go near an acute hospital in the first place, or to take people from the acute hospitals. But I think they need to be seen alongside a much better ability these days to treat people in their own home, to have home support, whether from social care colleagues or from health colleagues, as well as, again, in a place like Lincolnshire, a number of care homes able to offer services. So I think we need to look at the entirety of the offer matched to the needs of patients. And I think it's different now than it was. Some of it is just about the names have changed of cottage hospitals, convalescent homes. I don't know how far back we need to go in the health policy, but ultimately all those debates just go back to where's the best place to treat patients. And nowadays we have a very strong home first focus. Thank you.
Thank you. Councillor Allen, please.
Thank you, Chairman. I don't know where to start. I'd like to just carry on from where Councillor Smith was, in terms of, we do seem to be going back to almost reinvent things that have been in place or were in place many, many years ago that seem to work perfectly well, which have been taken out for whatever reason. My own personal experience is to do with my wife, who was in hospital a year or so ago and had all the problems that have been mentioned by a number of my colleagues here about being discharged. She couldn't be discharged once because when she was meant to be discharged, she couldn't be because they hadn't got the pharmacy sorted out. The following day, she couldn't be discharged because they couldn't put the transport in place to actually move her out. And the final one was that she couldn't be discharged because the home care agency couldn't commit to providing the home care agency work that was required to get her home. So a stay in hospital that should have been a matter of 3 or 4 days turned out to be 2.5 weeks. And she didn't like it in hospital at all. The last place she wanted to be was in hospital because she didn't sleep for 2.5 weeks because she was on a ward, a mixed ward, of orthopaedic recovery that had dementia patients on it who spent the whole of the night screaming that they wanted their mother, and the rest of the patients on the ward couldn't sleep. So she couldn't really wait to get out of hospital. The real difficulty I've got is understanding where the service provision is trying to go and indeed needs to go. Because, yes, we can get the multi-agency meetings in place, to actually try and make sure that all the various things that are required to discharge patients are put in place, including boiler repairs, if that's required as well nowadays. Because that's, luckily, I think she was then in summer, so she didn't really have to worry about the boiler. But what is important seems to me to be the bed availability that we have within the system. And indeed, it's becoming more and more important that bed availability does actually exist, because we have excess deaths at the moment taking place across the UK, and that will include Lincolnshire, because we have people that are dying before they can actually get into hospital. Through accident and emergency, or get into hospital through for diagnostics and elective surgery. And we have to improve that bed availability so that it can provide the service that's required to the people that actually need it. The question that I've got for our colleagues that have been doing the presentation is that the population of the UK has grown 10% over the past decade. As far as I can see, all that's happened over the past decade in the National Health Service is that beds numbers have been going down to the current level of 130 odd thousand that's available, with 15% or 20% bed block because you can't get people out of the hospitals. What is the number of beds availability that they are aiming to actually trying to provide, either by releasing the bed blocking situation or improving the number of beds that are available that can actually provide the service that's required by the population that exists at the moment of the UK, and actually is going to start to have some impact on the waiting lists that we've got. Because the other aspect is that people are going to be dying waiting for treatment. And unless we provide the beds and the service within the NHS system for those people, they will continue to die earlier than they should do.
Okay, shall I start with that one? I don't know if colleagues will want to join in. Yeah, sorry to hear about. I think this example of your wife. That's a good anecdote or micro point of all of the things that we need to get better at. You may in effect make my case for me about some of the internal efficiencies we need to get better at. To take out drugs and the transport, as well as some of the home care support. So sorry to hear that example, but I think it's a real life example of where we need to get better individually and as a system. On the sort of bed numbers, it's not, this is one of those ones, it's a combination of numbers of beds, length of stay of patients, as well as occupancy level, and which beds are we counting, and not just having bed numbers as the metric for whether the NHS can cope or not. Going back to my earlier comments about increasingly we're able to do far more either in virtual wards, in people's own homes, or in other people's beds. But you're right, we do need to work on what is the optimum number we at ULHT need. We've been operating at, Michelle will have the latest figures, well over 1,000 beds of late. Our plans had been predicated on 880 or thereabouts being the right number. I think that number is no longer the right number, but we need to calculate what would be a number if we were operating effectively around occupancy levels and length of stay, and able to get the medically fit out. And on the elective operations bit, hopefully colleagues will know when we were opening the extra theatres at Grantham last week, we're really clear that is our surgical hub for the elective work. So an increasing proportion of our elective or planned work will be done at Grantham, allowing Lincoln and Pilgrim to focus on the emergency side of our trust, as well as much of the planned work isn't about operations, it's about procedures or diagnostics or outpatients, making sure that we maximize the work we are putting through those parts of our organization. But I don't know, Michelle, if you need to say anything about bed numbers or some of the work we're doing about trying to re-establish what's the target figures that we should work, that's somewhere between the 880 and the 1,040 or 50 that you've had open of late.
Yeah, so we've currently got 1,020 beds open. So in terms of what that means, we've opened additional capacity on all 3 sites to try and respond to the acute demand and provide as safer care as we can by doing that. We also courageously as well took the decision nationally. The standard for medically optimised used to be greater than 72 hours. So from being deemed medically optimised, they were given then a period of 3 days to find a solution. It's now 24 hours. So the ambition is, against that statement, that every patient that's declared as medically optimised, if we haven't got everything in place immediately to allow that patient to go, it all has to be in place 24 hours later at a maximum wait time. And again, what that then does is promote the patient not becoming unwell again because of overexposure in the acute setting. So just coming on to the modelling, so we are just doing a piece of work jointly with the system in terms of what the acute bed offer needs to be to respond. Now, when we look at it, as we've said today, so we've got currently medically optimised across our acute sites 163 patients that no longer need acute care. And if we were to safely move those patients through in the manner that we've described by accessing the right service, that would have a significant impact in the way that we actually coordinated the emergency departments, those patients waiting for beds, and subsequently the impact on the ambulance service. So we know that we're there or thereabouts with our modelling if we continue to support medically optimised being discharged safely and as quickly as possible when that decision is made. In terms of elective, I just also want to just reinforce, so we're doing a lot of work now to make Grantham the elective hub, and that will be for all specialties going through. At the same time, we will continue to ring fence our day case facilities that we've got at Pilgrim and at Lincoln, and they are protected. We don't put emergency patients in those environments. We keep them as clean and as green as we can to provide that. For our point of view, just to give assurance, I put equal measure in terms of potential harm against non-elective as I do elective. for a variety of reasons, as patients move and have waited, they do have the potential, as you've described, to deteriorate. So they have equal priority and equal risk assigned to them, which is part and parcel of my day job to make sure that we don't put any patient that accesses our service at risk of harm, irrespective of their pathway. So I just wanted to add that to also add some context in terms of what we continue to do and continually monitor.
Okay,
Thank you.
Just got three questions myself. So my first question is, on page 26, third paragraph, the report states that one of the issues with the handover delays is due to overcrowding of EDs. Whilst I welcome the expansion of the EDs at both Pilgrim and Lincoln, do you feel you will have the staffing levels to deal with the potential increase of patients these expansions may well cause?
Can I come in, Andrew? So part and parcel of all of the plans and the build work were to actually recalculate the workforce. So we are now working towards that workforce increase in readiness for both Lincoln to be commissioned shortly and also the ongoing big build from a Pilgrim point of view. We know what it needs to look like. Again, what we've talked about is there are new pathways we're developing within our emergency department. So the single point of access and some of the diagnostic treatments through the single point of access. So we know what the workforce needs to look like. We have calculated the increase of patients attending the department. We've looked and scrutinised what they're attending the department with, so we can make sure that we've got the right professional in the right place that can respond to them. And sorry, your second question, I didn't probably write that down.
I think it was just around the increase, and I think you've covered most of that really with what you've had to say there. Thank you. So building on from that, in which areas are there particular challenges in terms of the staffing cover, and what new and innovative ways are being implemented to address this? And is overseas recruitment still something that's taking place?
So overseas recruitment is still taking place. We, from an A&E point of view, we go with the Royal College of Emergency Medicine's template for safer staffing, and that is based on number of attendances and also design and footprint of the department. We have initiatives called RAT, which is responsive and referral and treatment. And what that aims to do is it aims to treat the patient at point of access if possible and to move them through so that we don't burden majors, minors. We're also working with the UTCs to try and streamline through there the minor illnesses and the minor injuries. What you get in the emergency department is those patients that only can get care from the emergency department. Part of the work that we're doing with clinical vision talks about professional standards for colleagues, whether they be nurses, medics, or alternative providers. And that talks about a response. So they're now being built into the workforce in terms of, so it's not just about the emergency physician, it's about having the right professional to care for the patient at the right time. So all of that is being built in. So we have a number of fast track pathways whereby we can expedite patients out of ED into what we've called the same day emergency care. We're going to be expanding those in line with also the additional support that we've got from an emergency department. So as we expand the ED footprint, we're also expanding the footprint of those same day emergency cares. So again, we don't become overwhelmed and burdened. Clearly, this work that we're doing around discharge and flow, it means that we'll have more capacity care for patients because we won't have patients waiting for beds in the emergency department. Now, that in itself takes up a resource that you then can't free to do what the ED team should be doing. So the two go hand in hand in terms of our responsiveness and our resilience as we increase the footprint of our emergency departments and our same day emergency cares. Thank you.
Thank you. And again, just touching on the recruitment part, whereabouts are you struggling most with the staffing?
So obviously, it's across the board. So we know that, like most health and social care providers, the last 2 years that we've gone through has caused quite a bit of fatigue. ED and ITU, from an acute point of view, have felt that pressure. So we did have a number of levers. We're now doing overseas recruitment from a nursing point of view, and also making sure that we've got a role that is exciting and has development. So we're starting to see the nurses come back now. We've got better resilience from that point of view. We do have regular agency nurses working in our AD. So whilst they're a transit workforce, they're very familiar with the environments today. So we're starting to see that. We're building up on the advanced clinical practitioner and using all disciplines, and that's proving really, really well. We've got a really good ACP program now, and a consultant ACP that's leading all of that. So we're getting traction on that. So, and then medical staff, we do tend to be more in the market for overseas recruitment, but we have got what we call the CSER program, which is an internal program of development that moves existing registrars into the consultant level to be capable. So a number of recruitment initiatives are being taken. So we don't do too badly now from a recruitment point of view, and we're also retaining. But as I say, we did have those glitches where nurses left the profession because they were burnt out. So we've taken a slightly different route around that now. I hope that answers the question that you've posed.
And if I can, Chair, just in terms of trust overall and our vacancy level, which is now at 9.6%, that's the lowest level of vacancies I think this trust has had for a number of years. Certainly when I joined, 3 years ago now, it was up near 15% vacancy. So we are making improvements in that, and the numbers of staff we now employ compared even to a year ago has gone up quite markedly. So all of that going in the right direction. Thank you.
Thank you, yeah, and that's good to hear. My final question is, on page 29, first paragraph, the report highlights a new service from LCHS, which is clearly yielding positive results. Is this something that is looking to be expanded further as you move forwards?
Shall I take that, Andrew? So when I came into the system a year ago and worked closely with both Local Government Association and ESIST, who were doing a review of the system offer at that time, there was a very big gaping offer, and that was that we didn't have enough health supplied Pathway 1. So LCHS stood up a new service which went live December last year. They are working currently on a length of stay of 16 days. They currently have capacity to take just over 50 patients at any one time onto their caseload. More investment has been placed into that service, and we have a trajectory to deliver 75 patients on that caseload by the end of this month. In terms of workforce challenges, that is, I think, one of the biggest areas we struggle with as a system are those what I would call the band 3, band 2 carers to look after people in their own home. And we have to be very careful as a system that we don't rob Peter to pay Paul. So we need to invest and put more staff in reablement. We need to put more staff in LCHS. What we can't do is take staff out of the reablement service to work in LCHS. So we've been really careful and looking at innovative ways that we can go out jointly together to recruit, that if one company's gone out, then we make sure that we're not, that we have oversight on the staff that are applying for the jobs, and trying to make sure that we don't rob Peter to pay Paul, because that would be wrong, moving staff between health and social care like that. But the LCHS service, the outcome data that I've seen so far is extremely encouraging. Over 60% of the patients that go through that service need no further long-term care needs, and that's a real result. And the ones that do move on to need longer term care, their needs are reduced, so they don't need the 4 double up packages, 4 home visits a day. They're often moved on to just once a day or twice a day, and in fact very often the family can manage. It's had a lot of positive feedback so far, and it's something which if we were able to as a system, and it all depends on our financial settlements into the new year, our investment in Pathway 1 capacity reablement rehab, the service from LCHS, that is where we really want to be investing. We've put just over 4 million to date this financial year. I would suggest we need to go much further, but a lot is dependent on the actual amount of money as a system we are given jointly.
Okay, thank you. In which case, I'm going to move to a proposal, and my proposal is this: that we welcome the improvement works taking place to improve patient flow and discharge by all system partners, including evidence that ambulance handover times have been reducing since the introduction of the Breaking the Cycle initiatives. I'd also like to seek a further update for the committee on the 17th of May 2023. Do I have a seconder to my proposal? Councillor Underwood. All those in favour, please show. Thank you. That's supported. And I'd just like to thank you all for your attendance this morning, and have a good Christmas. Thank you.
Okay, thank you, Chair. Thank you for your questions. Same to you as well. Cheerio, bye.
Okay, we'll now move on to agenda item 7, the interim integrated care strategy. This item was circulated as part of the agenda on pages 33 to 36. And I'd like to welcome our presenters who've been waiting very patiently. Michelle Andrews, Assistant Director for Corporate Support for Lincolnshire County Council, and Pete Burnett, Director of Strategic Planning, Integration and Partnerships for the Lincolnshire Integrated Care Board. A PowerPoint presentation of the overview of the draft interim care strategy will be presented as well, I understand. So I'll hand over to you just for a quick run through, please.
Yeah, thank you, Chair. I'm going to start with the presentation, go through the obviously slides. Difficult because I'm obviously out. I am dialing remotely, and Michelle's going to do the back end of the presentation. I can't see the presentation up on screen at the moment, so could we get to that? Excellent, thank you. So yeah, so we're here to present on the interim integrated care strategy, present an overview on what we have done to date and the work that's taken place and what the strategy is kind of lining up as we get to the end of December. So can we move to the next slide, please? So what's it on here? So the integrated care strategy then. So guidance came out with integrated care systems and integrated care boards, requiring the setup of integrated care partnerships. There's a joint committee of the county council and the ICB. So if you've got 3 county councils in your ICB area, then there'd be a joint committee with them all in that regard. And the Health and Care Act requires the integrated care partnerships to develop an integrated care strategy, setting out how the needs can be met by partners across the integrated care system. So in most other systems, and all but 3 systems in the country, each integrated care partnership has more than one health and wellbeing board underneath, that form part of its constituent kind of area, and some go up to 3 or 4, depending where you are in England. In Lincolnshire, along with Gloucestershire and Somerset, we have only 1 health and wellbeing board that we're working towards. So the key here is making sure we have 2 documents that kind of connect to each other but have to be separate. So where in other systems, the integrated care partnership, it kind of builds up a level above the health and wellbeing board strategies. That's not the case for us locally. So we're, in the practical terms, we looked at that as a system and presented back that actually what we want our joint health and wellbeing strategy to be is the what. So what are the priorities that we're looking to address? What are the areas that are identified in the JSNAs that need to be addressed in the health and wellbeing board strategy? And the integrated care strategy is the how. So it sets out how key enablers what key enablers systems will focus on in integrated efforts to support the delivery of those joint health and wellbeing strategy priorities. So that's how we differentiate it. Ideally, you'd have 1 strategy for the system, but we're not really informed by Department of Health and Social Care that we can't have that. It has to be 2 separate strategies, but they clearly need to align, connect, and link together for the system. So that is our kind of context and approach to this work. Can we go to the next slide, please? So to start this work, we presented that the previous slide and our kind of our thought process between the 2 strategies in a meeting at the first integrated care partnership meeting back in September, and then we planned out a kind of a range of activities that we needed to kind of take place for us to write a strategy, because I think the key with all strategies is the engagement that goes into them, and the work that you produce in that engagement that kind of forms what takes place. So the key ones we were planning for kind of a development workshop, an integrated care partnership workshop that had integrated care partner members on it, the health and wellbeing board members, along with district council, representatives from primary care networks, members from the voluntary and community sector, all attending an event at the New Life Centre in Sleaford at the start of November. And that went through. That was a really strong event. We had public health present on what the kind of joint health and wellbeing need, well, what the needs are of the local population, how kind of inequalities maps out across the Lincolnshire county, and what the key kind of burden of diseases are, and that we need to consider as we form our integrated care partnership. We then went through kind of our approach, which we've just gone through, and then looked at the kind of key enablers that we wanted to focus on within Lincolnshire that we thought were the key priorities that should be form part of the strategy going forward. Because the guidance is fairly permissive, but it does reference about, I think it's 12 different enablers you might want to consider, and that could make it quite a long, arduous document to get through. And so what do we want to do locally? That was the key input from that meeting, and we'll get into that in the second part of this presentation. But that meeting was really helpful to say, well, this is where our focus needs to be. Alongside that, we had an integrated care partnership strategy involvement group. That has met monthly, and actually this month we met twice in consecutive days, and they were to provide advice and input to help shape the strategy. And that was really, our purpose was to facilitate wider engagement, involvement and input across wider networks. So that was quite an all-encompassing meeting. I had representatives from Health Watch, from the voluntary sector, from Lincoln, all at that meeting, along with the NHS Trust, local authority, district councils, to kind of say, well, this is where we are with the strategy, and constantly test our approach, constantly test the kind of information we've had in it that's formed part of the strategy to make sure actually it's in line with what people expected, and to gather their thoughts to help shape it as we get to the kind of final presentation of it. We also had a list of enabler leads, so where we've got into the key enablers, we knew who the leads were across the integrated care system on them, so they were contacted, and they've obviously shaped the kind of core content in that area. And there's also priority leads in the joint health and wellbeing board strategy, and they've been engaged to ensure there's alignment across the two strategies going forward. Here's the next slide, please. So our key ambition then, which will form part of the document, as we describe, is a simple one, and it is an interim or initial strategy. The plan is to do more work on this into next year. But our key ambition is for the people of Lincolnshire to have the best possible start in life and be supported to live, age and die well. And in all the meetings we've had, and we presented this back at the Integrated Care Partnership board meeting last week, should I say, and that's been well received. Initially, we didn't have the die well in, but the voluntary sector and colleagues said actually we need to be mindful that is clearly something that's going to happen to us all, and we need to make sure that is a good experience when we finally get there. So that's been added in. And then looking at that, we then said, okay, what are our shared aims? And if you look at the integrated care guidance and the legislation, that identified 4 core purposes of an ICS. But we felt actually they're fairly generic, and not that they're wrong, but they're nationally kind of defined core aims. And our feeling within the system was actually we should align with the Health and Wellbeing Board aims, which are the focus on prevention and early intervention, to tackle inequalities and equity of service provision to meet the population needs, to deliver transformational change, and to take collective action on health and wellbeing across a range of organisations. So we've got our ambition at the start, and then we've got our core aims that sit underneath it. And the key here is making that alignment back into the Health and Wellbeing Board strategy, so that these are clearly connected. Can we move to the next slide, please? This is the final slide, and I'll hand over to Michelle. So this is taken from the strategy, or the interim strategy as it's currently drafted. So at the top we have that ICS ambition, which we've just articulated, and then the ICS aims, which obviously come from the Health and Wellbeing Board strategy. Underneath that, as a system, then we've looked at kind of what are collective measures that we are looking to demonstrate we are delivering those ICS aims that are above them. So they've been articulated, they've been shaped from engagement from across the system, so they have changed over time. This is what we are, I think they've been slightly shaped since this has been presented. So for example, decrease on the left-hand side, decrease in percentage of physical inactive adults also now includes inactive adults and children, for example. So this isn't quite the finalised KPIs, but this is the measures, but these are pretty much in principle what we are looking to do. Underneath that, we have the 7 Health and Wellbeing Board strategy priorities, so they're clearly articulated. And then we articulate that actually the focus of this ICP strategies are on the key enablers, and those key enablers are identified there. So one is population health and prevention, one is workforce and skills, a further one on personalisation and personalised care, community engagement and involvement, and then finally information and information systems. So that's where we've got to this point. I'm now going to hand over to Michelle, who's going to go through the key enablers in more detail.
Okay, thank you, Pete. So next slide, please. So as Pete has described, we've gone on a range of investigations and communications and engagement with colleagues across the system. And out of the 12 enablers set out within the national guidance, these were the 5 that came out as identified as the most important to Lincolnshire through the workshop and the engagement that we've done to date. As Pete said, what we want to try and do is develop these across the system so we all have a shared ambition about how the Health and Wellbeing Board strategy and the Integrated Care Partnership strategy fit together and dovetail for us and are meaningful the way our system operate in comparison to some of the other more complex systems across England. So population health and prevention, it was felt, would be the golden thread through everything that we do. We felt that this was something that was really important to providing the care, improving outcomes for health, and tackling the inequalities we feel are currently within our health and care system. Workforce and skills have touched upon several times in the presentations this morning, absolutely imperative to the health and care system, but also developing wider workforce and ambitions for our citizens across the county, and we'll go through that in more detail. Personalisation, personalised care, giving opportunity for people to drive their own personalised care plan and how that fits in with the wider system, as we've talked about again on several occasions this morning through the other agenda items. Engaging our communities and how we use data information, our information systems, both on a personal level and an organisational level to drive forward greater integration and better delivery. Next slide, please. So with the strategy as we're developing at the moment, what we want is to develop an overview and an overarching understanding of how these enablers are going to drive improvement, avoid duplication, and reduce the gaps that may be available in the system, and how do we identify and drive forward improvement in those areas. So we've got population health and prevention. This is very much about self-care, about promoting how you can take care of yourself and your family through the various life stages as we go through, right from preconception and pregnancy, through early years, into childhood, adolescence, feeling that working age, what do we need to do to stay well, fit and care for ourselves and our family, age well, and as Pete said, now we've looked into the die well and what services we need to do and provide to enable us to best meet the needs of the communities. The second enabler is very much workforce and skills, and again, as I've said a couple of times this morning, we've focused on that, and interestingly, the 2 areas that have come up with the engagement are around inspiring young people to come in and stay in the health and care workforce through our engagement with schools, colleges and the university. And then the second is about how we work and train and support the people who are already working in health and care around the resilience, gaining skills, developing further training and support packages to thrive, for our workforce to thrive. Next slide, please. Regarding personalisation, the themes that feel are most important to us are around delivering personalised care, very much around supporting self-management of the care, and how do we make the most of social prescribing and community-based support mechanisms to reduce the need and demand on our acute and specialist services that we have available, so the right people get the right support at the right time. Enabler 4, very much around community engagement. The themes that came out there around collaboration across organisations, engaging our communities in co-production, looking at the community facilities and networks available, the value and importance of volunteering and recognising how we build on the knowledge and skills and the contribution that volunteers can make, and taking that forward then to our funding and how we use tools and data across the system to best meet the needs of our residents. Next slide, please. Finally, the fifth enabler was around data, information and information systems, very much around the two themes there around how do we use better and more effectively digital technologies for the care and health and delivery of that, both on a personal level and organisationally. And then the second is how do we use all the information data we have individually within our organisations and present that and create an information system that is robust, resilient and helps us to deliver, inform and commission services in an appropriate way. Next slide, please. So as Peter said, we have got the 7 priorities within the health and wellbeing plan that he showed within schematic earlier in the presentation. The orange section, they will continue to be the priorities of the Health and Wellbeing Board, and those working and delivery groups will feed in and continue to be accountable to that board. However, the Integrated Care Partnership will very much focus on the wider support the system can bring collectively, adding value to where we can work together better to improve things. And those 5 enablers I've just described will look to identify leads and groups that are already in existence or reshape the groups that are in existence in order that we can manage support and keep people accountable through that mechanism. Next slide, please. So the timescales, as we've said, this is an interim strategy. That's a directive from National that we had that very quickly put in place following the integration partnership development and the integration care board coming into being. The strategy needs to be in place in a draft form, in an interim form, apologies, in December, and that's why we've come to give you an information about where we are with that design of that. We're then looking to do further engagement during 2023 in the spring with communities on top of the work we've done already with key partners and stakeholders. Develop that then, there will be a further development which, regardless of this, of our joint strategic needs assessment, we expect to be in place by the end of spring. That will result in us needing to refresh and update our health and wellbeing strategy, and on that basis then we'll revisit our interim integrated care partnership strategy to ensure the 3 reflect each other in the way they come together. Looking to have then a longer term integrated care strategy in place that the integrated care partnership will govern, monitor and take account for as we go forward. Thank you.
Thank you. I've got Councillor White first.
Thank you. I'd just like to ask how public health strategy fits in with this. I remember Derek Ward's 2019 report, and I can't remember the exact terms he used, but he was talking about ageing without disability, etc. And I'm interested in healthy weight, because the obesity crisis seems to be increasing rather than improving. And I'm wondering what power the medical profession has to tell people that their health might improve if they lost weight.
Shall I take that? So with regard to Derek and the work that Derek's doing, Derek's part of both the Health and Wellbeing Board and the Integrated Care Partnership. The work that they do within public health informs all of the data that we have got. the physical activity and the inactivity of probably, I think the statistic currently about 30% of our young people are not as active as they should be, and we know that adults are not as active. And so what we want as a collective across the partnership is to raise that with all organisations in the interactions we have with the public. So it isn't just around medical professionals, it's about all of the organisations supporting people to be more physically active. That will remain a priority for the Health and Wellbeing Board, and we'll add weight to that by the integrated partnership, creating a greater focus on that. So hopefully it builds upon that, and we want that to be a great one of the key priorities for the system going forward.
Thank you.
Thank you. Are there any other speakers? No, in which case I've got two questions. Just thinking ahead, when will we be expecting further reports on the integrated care strategy? From the summer of 2023 onwards, for example?
So as we say, the draft strategy we are working on behind the scenes. This is to give you a flavour of the content of that. We will be looking to have an interim strategy available in the new year to the public, and then we'll go out for that consultation period during the spring, refresh it in line with the two elements I've said, with the Joint Strategic Needs Assessment, the Health and Wellbeing Board, ensure they all align and dovetail together, and then we'd be happy to come back perhaps in the autumn in preparation for the final version to be substantiated in December next year.
Thank you. And my final question, to what extent will the interim strategy and in future the full strategy influence the commissioning or commissioning decisions of the NHS?
Pete, do you want to take that one?
I think that's probably one for me, Chair. So the whole reason for the whole purpose for the strategy to be developed by December was that the NHS has to do a joint 5-year forward plan in the next 3 months, and the aim is for that strategy to inform what goes into that joint forward plan. So that's our operational plan, but it also sets out how the NHS will meet and the Integrated Care Board will meet its kind of legal duties. So that the purpose of this strategy is to make sure that it informs that plan going forward. So some elements of it aren't NHS to be involved with, necessarily to be heavily involved with. Other areas around prevention and public health, we have a bigger part to play. Personalisation, clearly we do, and information, data and systems. So when we do our 5-year forward plan, our data and systems plan within that needs to align exactly what the Integrated Care Partnership Strategy says in that regard, and we need to have kind of make sure that we're working in the same joined up way as described at the end of the presentation around that priority. So no, it certainly will inform it, and I think there's an acknowledgement that we need to make sure with the joint work we do next year with the health and wellbeing strategy, this strategy, that the NHS is more heavily involved than probably has been previously.
Thank you. Councillor Cleaver.
Thank you, Mr. Chairman. I'm pleased to see this document, and actually, in one sense, it's very good to see so much written in one place, covering such a wide range of issues and topics that clearly need to be addressed. That's not an issue. I think my concern is that it does read more like a wish list than a strategy. And what I'm not seeing here is any comment on how it's going to be implemented, the arrangements for accountability and for governance and for the appropriate organisational structures to be in place to actually deliver these things. And I hope that will come fairly shortly, because I'm receiving some feedback from members of the public who are more informed about these things, that's what they're waiting to see, that they won't have confidence in the new integrated care arrangements until they see something more concrete about what's going to actually be delivered, how it's going to be delivered, who's going to be responsible for it, and where the accountability is going to come.
So I'll pick that up in the first instance, and Pete may want to come back. This isn't a presentation that gives you an overview, a flavour of the content of the strategy. Obviously, the strategy itself will give more detail to that. the core purpose of setting up the Integrated Care Partnership, which is a statutory arrangement between the Integrated Care Board and the local authority, is to have a strategy that covers the system and that group of people hold the system to account in a greater way that we've had powers to do before. And so I feel that that's where the accountability lies, and this interim and the initial is the basis of the start of the journey, not the end. And we're hoping with more engagement, more input from organisations and more collective ambition for Lincolnshire that we will come together, and this will have a greater driving force than we have separately as organisations. I don't know whether P wants to add to that.
I will do, if that's okay. So I think the key here is, just build on what you just said, Michelle, these arrangements have only been legally in existence since July, which is not a great deal of time to expect or even put that into place, but that is clearly what we're trying to do, and that's what the back end of the presentation says around having existing groups or setting up new groups to drive forward the kind of key enablers within the strategy. Because of the timescales with the strategy, realistically, you'd rather have had a longer period of time, and actually would have done a lot of the work to align with the work we were doing locally around the Health and Wellbeing Board strategy. But national guidance doesn't always allow for that to happen. But the next steps is about saying, right, you're quite right. How do we drive? These are our enablers. Okay, what's the mechanism then for them being driven forward? I think the agreement is the Integrated Care Partnership will oversee the delivery of those enablers to make sure they have regular feedback on how are we getting on in this area. What work has taken place, what are the next steps, and what else do we need to do? So that's going to come with time, but ICP has only met twice, and the strategy yet isn't finalised. So that quite rightly this time next year, if you say, well, how are you doing it? We aren't clear. It'd be a relevant kind of question to ask us. But at this stage, I think we are clear on how we're going to move forward with that.
Okay, thank you. In which case, I'm going to propose that we note the process and the steps taken to develop the interim integrated care strategy, to note the timescales for producing the strategy to inform Lincolnshire's NHS Integrated Care Board's 5-year forward plan 2023, to note that the 22 to 23 is a transition year and the strategy will be developed further during 2023, and finally to agree to receive further updates as required during 2023. So I have a seconder for my proposal. Thank you, Councillor Woodson. All those in favour, please show. Thank you. That's supported. In which case, I'd just like to thank our presenters for your attendance. And we'll move straight on to agenda item 8, Acute Services Review Implementation. This item was circulated as part of the agenda on pages 37 to 44. And once again, Pete, we'll hand over to you. I think we all take the report as read, so just quick introduction, I think.
Yeah, no, thank you, Chair. So just a quick go through where we are with ASR. So the CCG, when it existed, signed off the business case, the decision-making business case back in May, and that was around changes around orthopaedics, surgery, urgent emergency care, acute medicine and stroke services. So since that time, we've set up a implementation oversight group. That comes with partners and clinicians from across the system to oversee the kind of delivery of the 4 kind of different service changes that exist within there. That includes LHS, ULHT, and it's a meeting that I chair. And underneath that, then we have implementation groups for each of the kind of core services. So there's just a few points. I know it's part in the paper, but I want to touch on really. So orthopaedics, that was a pilot that took place since 2018, so it was the quickest one to enact and go live, and the team there have been spending their time working on making it a permanent basis going forward. But the actual outcomes that we've seen from that service have been excellent, to be fair. And so if you look at some of the measures that are included in the paper, so for length of stay for primary hip replacement, that's now at 2.5 days. That is the second best in the country for length of stay around hip replacement. And for actually knee replacement, that is now the best in the country for knee replacement, as seen a significant improvement since before the pilot times. ULHT has also become one of only a few select hospitals to carry out specialist suprapath keyhole procedures. and these take place at Grantham Hospital. And what that means is that if you need a hip replacement, you can have them both done at the same time. So that improves your recovery and reduces any length of stay and reduction in kind of risk in terms of infections and anything else that comes into it by doing that. So that's great news for our local residents. And also from referral to treatment times, in terms of its peer trust, United Lincolnshire and Orthopaedics is the best in the country. And in terms of all the NHS trust in the country, it's ninth. So incredibly high kind of standard in terms of delivery of the orthopaedic service. And in the paper, there is we've had 100 compliments since April of 2021. And in the paper, it outlines kind of there's 3 kind of patient experience feedback we've received through that going forward. Other thing to highlight though is also not only is that it's now kind of considered very high in terms of NHS standings in terms of delivery. Grantham is now being designated one of 8 surgical hubs in England, and we're all focused on orthopaedics, ophthalmology and general surgery. And the aim of that is to kind of speed up waiting list times, and some of the key work that, because the ULHT's RTT performance is strong in this area, is actually taking work on from other systems that are struggling to get through that work. And the Getting It Right First Time team have identified as the Lincolnshire model's best practice nationally to enact. And Professor Tim Briggs, who heads up that team and is one of the lead orthopods in the country, is keen to make sure other systems take heed of that. In terms of access, we've obviously said as part of the consultation we would have outpatient clinics remain across all sites. That has happened. Consistently, 7% of all follow-up appointments are undertaken virtually. It will have to be done between April and October. And also in terms of people within the Lincolnshire postcode, we've had 595 people in between October of last year and this year have orthopaedic procedure at Grantham, and 18% of them come from the Louth, Mablethorpe and Alford areas. So it demonstrates that patients are willing to travel for good kind of excellent orthopaedic surgery, and they can also enact the kind of public transport. And to date, we've had no cancellations due to transport issues moving forward. Since the kind of pilot went live, only 3 patients have been transferred, but that isn't because of the orthopaedic procedure. It's to do with other kind of specialties needing to assess their need going forward. And the limb kind of fracture clinics, there's still the ability to put them in at Lincoln, both in an outpatient procedure and for a kind of any kind of outpatient procedure, and also just for the fracture clinic beforehand. As well as being a surgical hub to support that, the Trust have had 2 new theatres open this month. That's a £5.4 million investment into the site, so significant investment to make it the centre of excellence that we kind of said we would do. And that builds on the £1 million investment that we had that's taken place between 2020 and 2022. So a really great news story, and commend colleagues at the hospital at ULHT in terms of you need to have the kind of the plan for it, but they've enacted it, and the outcomes are excellent. So which is good news. In terms of the other areas then, so obviously that was a pilot that had been in existence for some years. The other bits then is now taking the plan from the decision-making business case into implementation. So what we've done with our urgent emergency care and acute medicine beds at Grantham Hospital, we've amalgamated them together because actually the work needs to be dovetailed together as we work forward. There's clearly synergies between both service proposals, and there's clearly linkages when they get enacted going forward. So that's what we've done. We broke it into 3 stages. So we're currently coming to the back end of the first phase. That phase is development of the service specs for both the UTC and integrated community and acute beds. The next phase is dependent on legal advice, but they're the procurement requirements that might be necessary to go with that. And then the final stage will be implementation of the new service. So the first stage we have to consider, and the CCG and now the Integrated Care Board to consider, is kind of what kind of procurement is needed across all services. Advice and guidance, well, the legal advice we've had is that the UTC may need to go on to procurement, but it really depends on the service spec model and the integration with the hospital. So what the key outcome of the service spec work will then determine kind of where do we go with this? Do we need to go out to procurement? Because there are national firms that do provide UTCs, but as we've always said, this isn't a generic UTC model. It has admission rights into the hospital. It clearly has step up bed facilities into those acute community beds, and therefore it's not quite the same model that so that not everyone else can provide that. So that was something we'll consider after phase 1. So the first phase then is the scoping out of the service specification. We have a strong system group, so it's made up of clinicians from ULHT, LCHS, staff within the A&E department at Grantham Hospital, so the matron, consultants within the hospital, general practice. We have a public member on the group as well, and they've been working through the service specs. So we didn't start from scratch. There are national service specs, but also we had a model that was in our decision-making business case and our pre-consultation business case, and the service spec builds from that point. But key here is making sure that specification is correct, because that's going to last for a long time going forward, and those clinicians and those managers need to make sure that all the detail in it is effective and is something that they can support before we move into the kind of next stage of potential procurement and implementation. So the draft specs, the Grantham one is as a draft is complete. The community acute service beds one's now what's being finalised. We expect that to be done by February. Once completed, it will then go through the Integrated Care Board for approval. So at the moment, they're not approved specs, but they are draft, and they are then supported by the people around that table. Once we have that, we'll make that decision on the procurement process, and we'll be able to advise the committee on what the next steps are in that area. And then finally on to stroke services. So the key proposal here is the consolidation of stroke service at Lincoln County Hospital. That has 2 parts to it. So the one is a single Lincolnshire stroke service, and then it's the estate development that needs to take place at Lincolnshire County Hospital. So there's been regular fortnightly meetings really to take forward these 2 elements together, and the aim is to actually bring them together into one meeting, and also key focus on kind of a performance dashboard to ensure that actually what is required and the key measures of success around length of stay, patient outcomes are being measured collectively by that group. So a joint group is now in place between ULHT and LCHS. They've had a number of workshops. The second one, which was held in November, that's bringing together the clinicians, the nurses, the service managers that are involved from both organisations to pull together a single stroke service standard operating model. And obviously that means that's across the whole stroke pathway, and that sets out a number of medium long-term requirements to kind of improve that pathway going forward, and in line with the kind of estates development that's taking place at Lincolnshire Lincoln Hospital. A clinical operating model workshop that has reviewed many areas of pathway as taking place, and that's identified improvements that can take place. And the aim is to hold a perfect week. I think it was this week. I'm not sure. I haven't got the detail on that. I'm not sure if that's happened because of potential strikes taking place from the ambulance service. But the aim is to have a perfect week to look at that whole stroke pathway to make sure those teams are aligned. And the anticipation is there be a single operating plan developed for stroke services by the end of December. Added to that, we've increased the level of staffing in the community team, so that's gone up by 9 against the kind of target of growing that team by 15, which we are required to have that kind of rehabilitation across the county. And then secondly to that is the estates development. Expectation is to have the kind of strategic outline case developed by March, with, if you go through the steps as outlined in the paper, the full kind of construction completed by January 2026. So that's it as a run through the paper. Happy to take any questions.
Thank you, Pete. I've got my first question from Councillor Ayworton.
Thank you very much, Steve. Mr. Chairman, as you know, Grantham A&E has been closed since August 2016 on a temporary basis overnight. Currently, it's only open 8 a.m. to 6:30 p.m. with out-of-hours service. On our local campaign group, Grantham Save Grantham Hospital Facebook page, there are many people who are distressed that they cannot get appointments out of hours and having to travel to Lincoln Hospital, which I find very distressing myself. Can you tell me when the UTC will be open, if it's going to be open one day? Will it be open still 24 hours? And what mix of doctors will you hope to be deployed at the UTC? Thank you.
Thank you, Councillor Wootton. So I can't tell you when it will be open because there's a procurement process and the length of that procurement process. The aim is to be open next 12 months at the very latest, ideally before that if possible. It will be, as we said during the consultation, it will be a 24/7 open access service. So that will be there, so people will be able to attend without appointments. And there will be the opportunity to book an appointment because 111 won't allow that to happen, but you will be able to just turn up and be seen. But in terms of the numbers of doctors, no, I can't confirm that at this stage until that spec is approved. That I outline kind of service models. I can't say that at this stage, but there is, as it said in the decision making, as it said in the pre-consultation business case, the expectation to have consultant oversight and also mid-grades working in the department. How that's going to work is being developed currently.
Chair, if I could come back, Chairman. Initially, when this was proposed, we were told that the UTC was going to be UTC Plus or a bespoke service. Could you elaborate on what sort of service will be provided, please?
Yeah, so just to confirm, categorically, I've said this last time, it isn't a UTC Plus. That was when we developed the business case. We had a model that actually locally wanted to call it a UTC Plus. As we said at the last time, I think I presented back in June and previously last year, that we were told nationally you can't call it a UTC Plus. That isn't national designation of a UTC. So it is a UTC. UTCs across the country have different service specs, have different open hours, as you'll know, even within the county. But yeah, this is an enhanced service model. This will have general practice working there with community nurses, with mid-grade doctors. So it isn't the same service spec as identified elsewhere. And as we said during the consultation, the expectation is that 97% of patients who are seen currently at Grantham will be able to be seen at the UTC. And those additional people isn't because of the service change there, it's because actually partly national kind of guidance in terms of respiratory pathways requires 2 patients to be transferred to Lincoln, averaged out. So, but it will be an enhanced service. Once that service specs agreed, and once we can go to the implementation phase, clearly there's a significant piece of engagement and communication work on exactly what that is. Will need to take place with the public, so they're fully aware of the kind of scope of the service going forward.
Thank you, Chairman. Use the word enhance, which is good to hear. Thank you.
Thank you. Councillor Linda Wotton.
Thank you, Chairman, and thank you, Pete, for your presentation. But I feel that the people of Grantham and the surrounding areas have been in the waiting room since 2016. And now we've just got the appointment. But like all NHS and councils, it's all about the outcome. And we really need an outcome as soon as possible. So I say to you, Pete, why go to procurement when the systems are meant to be working together in a joined up way? Surely it would be best for providers to deliver local integrated services and not go out to seek an outside provider. I think we've learned lessons. Our A&E, our version of A&E was closed in 2016, and when you were taken to judicial review, you had to reinstate it. So we really do need answers, please. And I understand we need the right service because we have to accept that we're going to be a UTC. And you have given us some clues of extra things we're going to get. So I just say, can we get on and do it so we all know where we are and what service we are going to get? Thank you, Chairman. Thank you.
So, do you want me to come back on that, Chair?
Yes, please, Pete.
Yeah. So I agree. We do want to get on with this. The key work here is we need to get the work done properly. There's no doubt about it. We can't go with a half-baked specification, a half-baked service. We need the population in Grantham, because you say they have been waiting a long time, and we need to make sure that when the service is enacted, it's one that's going to stand the test of time, is going to maintain patient safety, deliver the patient outcomes that I think we'd all want to see. I don't disagree. We can't sidestep legal requirements and legislation that says you have to go out and procure. So but our aim is to try and avoid that where possible, but we have to abide by the law. Obviously, you have to remain lawful as a public sector body, but it'd be great if we can avoid that to speed this up, work with local providers, and that would be our intent if possible. But the people who are involved in this spec group have to sign conflict of interest registers, for example, and they are there as advisors, not to fully spec it out at the moment in time because it might kind of impact legally going forward in that regard. But no, so we do want to get it in. The sooner we can get it in, the better for everyone, better for the service, better for the staff working there, better for the patients. But we just need to make sure we go through this process properly and effectively as possible. But if we can, the sooner we can get it in, that is our aim and ambition.
Thank you for that, Pete. I'm glad you mentioned staff, because we do speak to staff and staff do speak to us, and a lot of them are terribly unhappy because they really don't know what's going to happen. So can you assure us that you will communicate with your staff before you make any changes? Thank you. Thank you, Chairman.
Yeah, clearly staff are the bedrock of this service model, and the matron for Grant from A&E is involved in the service spec work, and clearly the need to articulate once that's agreed and the next steps, they're critical for the delivery of the service going forward. So yes, we will engage with them in terms of what that's going to mean, how it's going to operate, but their senior level staff are already involved in developing it to make sure it's fit for purpose going forward. But yes, no, we certainly will be doing that, as well as with the public as well, because it's equally vital to do it with them at the same time.
Thank you, Councillor Hutton. Councillor Smith.
Thank you, Chairman. I won't rehash my concerns around stroke as I've mentioned in the previous debate, but I still have them. I appreciate that things aren't as further on developed with that pathway as others, so I shall await that with some interest. All I'd say, Pete, is you touched on transport around a reason for cancellation. I'd be very, very careful, because if you have a very good friend who needs help, or if you're a parent, even if it will make you financially difficult for a period of time, if you think they really need that appointment, come hell or high water, you'll get them there one way or another. So I'd be very careful with using the data to say it's not a problem, because Lincolnshire is a very rural county, and we all know public transport in certain areas of it, especially rural areas, let's be frank, isn't really there, isn't really an option, isn't practical. So it might not have been stated as a reason, but it is a factor and it can still be a problem.
Yeah, so just to come in on that, I agree. It is in a rural county as large and as dispersed as Lincolnshire, it is a key factor, and it will cause issues to people. What I said was it hasn't led to any cancellations, but I fully agree. People, thankfully, hopefully, you won't need orthopaedic procedures that often, and even when the stroke comes in, stroke service comes in, the transports around that. Hopefully, you have 600 strokes. 1,100 strokes a year in the county at the moment in time. So hopefully it's not a service you enact with too regularly. But I do agree it is a challenging position, transport, and it maintains a key focus of ours, but not with easy solutions either.
Okay, thank you, Pete. I haven't got anyone else that's wishing to speak, so I've got 3 questions myself. My first is, with regard to the stroke services, how confident are you that you will achieve the funding required to expand the stroke capability at Lincoln, and what happens should the funding not be gained?
I am confident we'll get the funding required to do that. As a commitment, as when the decision's taken, that the funding will come through. Clearly, there's inflation and elements of that work through in terms of how that's funded and what the cost will be as we get to 2026. But yes, the system's committed to funding that change. It has to happen to enact the service model that's going to lead to better outcomes for the patients, as we've identified in the business case. The practical steps we might need to take at that stage we'll have to address as we get closer into it. But much like the Lawton Leeds that LPFT are involved with, where the funding's changed, they've then gone back and secured the funding securing the funding to take that development forward, and we'll just have to enact the same kind of processes they've done at that stage. If for example, the bill's more significant than we expect it to be.
Okay, thank you. Page 43 of the report refers to the single Lincolnshire stroke services, with discussions involving United Lincolnshire Hospitals and Lincolnshire Community Health Services. Will a single service look to include other acute providers for Lincolnshire residents?
Not currently in the scope of that work, but it's a valid question, because obviously they're a single service delivering from stroke. They're patients that go through the acute stroke kind of pathway into United Lincolnshire Hospital and then back out into the community and having their rehabilitation. So it's that kind of model that we need to work on, but we do need to work with hospitals both in Grimsby, and obviously they've got their own acute service change. So part of the thing is working out kind of what the impact of that might be, and also with the with MWAFT down in Peterborough, because we still need to make sure that those patients are then transferred into LCHS's kind of care, and there's work that takes place with them, and we have had discussions with both organisations on the model. But no, the integrated team itself is a ULHT LCHS as a single team model, but it doesn't mean MWAFT and NLAG to the North West can't transfer patients into that service.
Okay, thank you. My final question: how is the overall implementation of the ASR items being affected by the challenges of recruitment and retention?
Well, they do. I think orthopaedics has shown that if you get the model right, it does make you more of an attractive service to come and work in. There are challenges. Stroke, there's a national shortage of stroke physicians across the country. So the key there is getting that model right, demonstrating the investment into that service, and will help support that going forward. And the UEC and the acute community beds at Grantham, again, there's national kind of shortages, but again, we need to confirm that once that spec's in place, people know it's going to be in place for some time. We hope that will then help them build and strengthen their workforce. But you can't get away from the national challenges that the NHS face on workforce. But I think certainty will certainly help people go, right, I can go and work there, I know what that model's going to be. And demonstrational investment will also help with that. But there are other factors that you need to play into it. I think the medical school and the work with integrated care strategy has around workforce as well, and the people board in the NHS also have a role to play.
Okay, thank you. In which case, I'm going to make a proposal that we welcome the progress with the development of a Centre for Excellence for Orthopaedics at Grantham and District Hospital, including the higher levels of performance, the positive feedback from patients, and the 2 new theatres. That we note the development of a single Lincolnshire stroke service, and request that the committee is notified of NHS Lincolnshire's Integrated Care Board decision on whether there will be a full procurement process for delivery of the Grantham Urgent Treatment Centre and the Integrated Community and Acute Medicine Services at Grantham. Do I have a seconder for my proposal? Councillor Ray Wotton. All those in favour, please show. Thank you. That's supported. And I'd just like to thank Pete for his attendance and wish him a nice Christmas. Thank you.
Yeah, thank you. And wish you all a Merry Christmas as well. Happy New Year.
And to you. Take care. Okay, we'll move on to agenda item 9. The work programme. Simon, over to you.
Thank you, Chairman. Very briefly, there are no changes to the forward work programme printed on pages 46 to 47. So given the time, I won't highlight any particular items that are coming up, and just will take questions and suggestions. Thank you.
Thank you. I've got Councillor Smith.
Thank you, Chairman. I would be most gracious if we could add something on the question I asked for the work programme in your announcements in relation to the duty to regard. Thank you.
Yeah, we'll make sure it's within that. I think it'd probably be less likely to be an item directly to committee and perhaps something that we do outside of. But yeah, we'll ensure that goes down anyway. Any other comments, please? No? Okay, in which case, I think we're happy to move that we note the works on the committee's programme. So thank you all. Thank you for your attendance, and just to wish you all a Merry Christmas and a Happy New Year. Thank you.